Every minute counts when it comes to stroke, and on this World Stroke Day, the message resonates louder than ever. Every minute matters. Every year, millions of people across the world experience a stroke. Most of us think of clots and blockages, the kind that stops blood from reaching parts of the brain. But there's another kind, one that's quieter, deadlier, and far more unpredictable: a hemorrhagic stroke. A sudden rupture of blood vessels within the brain, a silent bleed that builds pressure, compresses delicate tissue, and in minutes changes the course of a life. In India alone, nearly 1 in every 5 strokes is hemorrhagic, and yet awareness about it remains dangerously low. A simple headache is brushed aside, dizziness is ignored, a moment of weakness is dismissed as fatigue. But behind these small signs could lie something catastrophic, a bleed that can claim a life before help even arrives.
Even a small amount of bleeding, 20 to 30 milliliters,
is enough to cause swelling, pressure, and irreversible damage. And still, many delay getting checked. They wait, they hope it will pass, and in those lost moments, what could have been treated becomes untreatable. In this episode of Rebooting the Brain, Dr. Sharan Srinivasan sits down with Dr. Krishnaprasad, a neurosurgeon whose life story is as inspiring as his medical insight. From growing up in a small village in Kasargod, studying in a Kannada medium school, to fighting his way through the challenges of government medical colleges with little infrastructure, poor facilities, and long nights of self-learning, his journey is one built on perseverance, humility, and purpose. From those beginnings to performing some of the most complex neurosurgeries in Bangalore today, Dr. Krishnaprasad's story is a reminder that resilience is not built in comfort, it's built in persistence. Together, Dr. Sharan and Dr. Krishnaprasad delve deep into the world of hemorrhagic stroke, how these bleeds happen, how doctors decide when to operate, and how every second between a headache and a CT scan can define survival. They talk about real patients, people who come in just in time and others who didn't. They also speak about something larger, the need for awareness, the need to take blood pressure seriously, to stop ignoring symptoms, and to understand that preventative care is not an option, it's a responsibility. Because high blood pressure remains the most common, most silent, and the most dangerous cause of brain hemorrhage. And yet, it is also the easiest to control. Sometimes, all it takes is 1 tablet a day, a small decision that prevents a massive tragedy. This is Rebooting the Brain, and this conversation proves why every minute matters.
Jnananandamayam Devam Nirmala Spatika Krutim Adharam Sarva Vidyanam Hayagrivam Upasmahe Adharam Sarva Vidyanam Hayagriva Upasmahe Hayagriva Upasmahe.
Rebooting the Brain, powered by PRS Neurosciences. Namaste, everybody. Welcome to another episode of our podcast, Rebooting the Brain. As usual, we'll start with the customary shloka. Om Asatoma Sadgamaya Tamasoma Jyotirgamaya Mrityorma Amritam Gamaya. Om Shanti Shanti Shanti. I love this shloka, and this shloka has been a driving force for me from my childhood. As the shloka says, from ignorance to enlightenment, from darkness to light, from death to immortality. You can use this shloka anytime, anywhere in your life, and get the kind of result that you want, applying it everywhere. Hi, everybody. My name is Dr. Sharan Srinivasan. I'm a stereotactic and functional neurosurgeon from Bangalore, India. Before I dive into the topic of the day, the housekeeping rules, please subscribe to our channel, Rebooting the Brain on YouTube. Subscribe to our Instagram channel. Hit the share, like button, and the bell icon so that you can get a lot of the videos that we are already streaming there. Don't forget to watch the prior videos. Each of it is a gem by itself. And also there's a Rebooting the Brain book, which is an Amazon bestseller. Make sure you get it. There's so much of neuroscience information. Very few people understand the human brain and the way it works, or worse, when it doesn't work. So today we have another important topic. On the World Stroke Day, we are going to talk with a senior neurosurgeon about hemorrhage inside the brain, bleeding inside the brain, or what we call as brain hemorrhage. So guys, help me welcome my dear friend, a colleague I've been working with for the last 12 years since 2013, Dr. Krishnaprasad. Krishnaprasad, welcome to the show.
Thank you.
I was waiting to get you on the show, and I had to select the right topic. I want to start with one story. Yesterday, I was consulting in the OT changing room, and one of our old patients walked in. And she, maybe mid-30s she was, and she said, "Sir, ನಿಮಗೆ ಇನ್ವಿಟೇಷನ್ ಕೊಡಕ್ಕೆ ಬಂದಿದ್ದೀರಿ. ಏನಂದರೆ ಗೃಹ ಪ್ರವೇಶ." So she was so excited. ನೀವು ಬರಲೇಬೇಕು, ನೀವು ಮಿಸ್ ಮಾಡಬಾರ್ದು. I mean, she was like really committed that I show up there. And she was so happy, smiling. But the starting was not that good. This lady had a brain hemorrhage, maybe about 6 months ago. And she had high blood pressure. She bled into the center of the brain, as you know, as the Pontine hematoma. She had a Pontine hematoma. She went to a nearby hospital. Her brother is a radiologist, Sarana, and they had to intubate her because she was deeply unconscious, put her on the ventilator. And then the radiologist wanted us to treat, so they came to our hospital. So the next day morning, when I actually went there, she was so deeply unconscious that the intensivist was wondering, is she going to make it? She's not going to make it. She looked so sick. I said, we have to fight. There's no other question. 3 weeks in the ICU on ventilator. She took 1.5 months to wake up. And today she walks into my OPD. Can you imagine? It is so gratifying to see that despair and this, joy that happens at the end of the day. So intracerebral hematoma, brain hemorrhage. So can you tell our audience a little bit of what is this brain hemorrhage? Clot, hemorrhage, hematoma, a lot of different words people know. Can you enlighten them on that?
So all these words, clot, hemorrhage, or hematoma, they're all same. Basically, textbook terms, the clot in the brain, in the sense, I see intracerebral hematoma. Other than trauma or aneurysm bleeds, we say all those bleeds as intracerebral hematoma.
Or ICH.
ICH, yeah, in
Correct.
short, ICH.
Correct.
So we can categorize into two types, basically.
Okay.
Primary ICH and secondary ICH.
Got it.
So 15% of these strokes are because of this ICH.
Correct. The other 85% is ischemic stroke, which Anil, we have an episode on that already by Dr. Anil.
Yeah. So what we mean by primary ICH means any bleed because of the hypertension. So it can be, high BP, risk of brain and hemorrhage.
Correct.
Yeah. Basically because of the hypertensive changes, what can happen in the vessels because of the poor BP control or long-standing hypertension. Sometimes it ruptures because of the sudden increase in the
It's like
BP.
a pipe bursting.
Yeah.
Correct, alva?
Yeah.
It's like some burst happening because of high pressure.
Yeah. So there are some common areas where we get this bleeds, like putamen, thalamus, then cerebellum, subcortical, other areas,
Correct.
brain stem.
Correct.
So these are the common areas.
Got it.
So the other type is secondary intracerebral hematomas.
Correct.
So they could be because of other causes than hypertension, like
Like
AVM bleeds,
Okay.
cavernoma bleeds,
okay. Some defect in the blood vessel, which is
angiopathy,
called
coagulopathies,
Correct.
some blood thinners. Some patients may be taking blood thinners. So such situations, uncontrolled, unchecked anticoagulopathic treatments may cause bleeds. Yeah.
Got it. So we'll go deeper into the things later. But so you are saying, like, let me see if I understood you right. High BP is one of the commonest causes of this.
Yeah.
But I keep seeing patients saying, Sir, ನಾನು ಗೊತ್ತಾಗ್ಬಿಡುತ್ತೆ ಸರ್ BP ಜಾಸ್ತಿ ಆದಾಗ ಸ್ವಲ್ಪ ತಲೆ ಸುತ್ತತ್ತೆ ಸ್ವಲ್ಪ ಹಿಂಗಂತೆ ತಂಗಂತೆ. Why are people so stupid? 5 paisa tablet ಅಲ್ಲ. Some of the tablets are 5 paisa, 10 paisa, not in 1 rupee. They refuse to swallow that and they come and spend 10 lakh rupees, 15 lakh rupees, 20 lakh rupees and they don't become normal again. So how important is checking blood pressure? See, taking the tablet is one thing. Taking regularly and managing. How important is all those things in your experience?
In the society, when you speak to the people, many people think if you take tablets for 6 months or like that, the hypertension gets cured, which is not true actually. And
Alva.
we really have to, the physician who treats them has to educate.
Correct. It's a very valid point.
It's a continuous process.
Lifelong.
Yeah. So I usually keep telling the patients, see, it's like how when you prepare sambar, you have to check the salt, the sweetness and all those things, which depends on the volume basically.
Correct.
Similarly, every patient needs upgradation of its treatment.
Correct.
So which many people don't do it.
A lot of people think
they continue keep taking the tablet for 4 years, 5 years without consulting doctors.
Correct.
Then all
Without
the scenario
checking.
changes and suddenly I'll end up with a large bleed, uncontrolled hypertension.
Very true. And I've had patients who say, they come with hemorrhage. I ask the family, BP medicine thought, BP idya houdu sir ide. BP medicine thought regular thought ide sir. Then I have to ask the next question. Then ratri thondra. Sir, one day besides. So it's like daily wages, sir. You have to take it every single day apart from checking. That's a very important thing that they say. And they don't realize that, BP becomes normal because of the tablet and not because it got cured. I think that's a very valid point. I think if there's one message, guys, that you have to take from this podcast, remember, high BP causes brain hemorrhage. Taking the BP medicine regularly, checking it, and also at the end of the day, periodically checking and taking it is one of your best insurances against brain hemorrhage risk. Now, these are people who know BP. How many people come in without knowing they have BP?
The other thing is, many people, when we ask, did you have a BP? Then they say, no, he doesn't have BP. Means they think if somebody gets angry,
Correct.
then he's having high BP.
Correct.
So,
You're right.
There's a false conception people have.
Anger is not BP.
Anger
BP.
is not BP.
Correct.
Yeah.
Very true. You're right. Even educated people,
Yeah.
say that at the end of the day.
Yeah.
Very interesting.
So periodical checkups, maybe after 35 or 40 years, annual checkups with the family physician should help them in diagnosing such type of problems.
KP, we are seeing younger and younger people coming nowadays. Who's the youngest primary ICH? How young has been the patient that you have seen?
Maybe 25, 26 years.
Alva?
Yeah.
So why
30.
is that? Why are we seeing it earlier and earlier? Any particular reason?
Like obesity.
Lifestyle problems.
Yeah, basically lifestyle problems.
Lifestyle habits.
Yeah.
Sedentary habits and
Yeah.
things like that. I think that probably causing that. So you are talking about the clot in the brain, and you measure the clot, and you're looking at whether the pressure is high, ICP, perfusion pressure, and everything else. You also told our viewers that every intercerebral bleed or ICH or hemorrhage does not need surgery. Now, before we go into surgery, people think bleeding about continuous ಆಗ್ತಾನೆ ಇದೆ ಅನ್ಕೋತಾರೆ ಬೆಳಿತಾನೆ. Is it really true that it's continuously bleeding or what exactly?
That is a common question. Once when we counsel, the attender, the first question, did the bleed stop?
Correct.
For which we don't have an answer. Either we should say a lie that nothing is there like that. So I usually tell, see, it's like a scan is like taking a photograph. It only tells the information at that point of time when the scan was done. So I also really don't know whether it's going to rebleed or not, whether the bleeding is stopped or what. What we can discuss is at that point how the scan is the same, what can happen in future in the next
So it
few
can bleed
hours.
stop rather than bleeding. That's what you're trying to say.
Yeah,
no?
yeah.
Correct. Based on the high blood pressure, how well you control it, and all other factors. So now the BP. So how much is the hemorrhage? People think tumma blood hogi there. Normally in a brain hemorrhage, how much is the bleeding that happens? What is the size, the volume of the hemorrhage that you normally see?
Average, it's what we commonly see is be around 20 to 30 cc.
Correct.
So yeah, so basically
maximum 50 cc, 60
yeah, 50
cc.
cc. Yeah,
Very rarely it's much bigger than
yeah,
that.
yeah.
So what are the symptoms? What are the common symptoms that patients come to us or are brought to the emergency or when they come and see? What are the common symptoms? that you
The
see?
common symptoms basically all depends on the site and location of the hematoma
Correct.
plus the size of the hematoma.
Correct.
So, for example, small bleeds may not just cause a headache, and they may report to us with the headache. Some I feel dizzy, like that. Large blood clots can make a person unconscious, sudden unresponsiveness, and they may be brought by the relatives, attenders.
Correct.
Some
Found
people,
lying in the bathroom.
yeah.
Or so,
some hematomas which happen in the lentiform nuclei area or thalamus area may have one side weakness,
Correct.
hand and leg weakness. Some people who may have brainstem bleeds may develop a weakness of all four limbs.
Correct.
Some people, when there is a bleed and a ventricular extension, they may develop hydrocephalus. Even cerebellar hematoma may cause compression on the fourth
Correct.
ventricle, cause hydrocephalus, where again they become.
So now you are saying that either if it is small, they can remain conscious.
Yeah.
If it becomes suddenly big, they'll become unconscious.
Yeah.
That's the first thing that
Yeah.
you're saying.
Yeah.
Apart from weakness on one side or both sides, depending on the location of the hematoma. This
Yeah.
is what I learned from what you said.
Yeah.
Now, so the question is now, everybody gets headache. You may get a headache, I may get a headache, some people. So which headache is important for them to self-medicate? Which headache they should go to a doctor and consult, or what should they do? How do they give cognizance to the headaches? Because headache is everyday problem to me.
The headache is a very common problem, like ordinary fevers.
Correct.
It's a very common.
Correct.
Some headaches which are very consistent in the sense the patient himself will feel it's not normal for me
Correct.
than the regular days or regular headaches.
Correct.
And continuous headache persisting even the night with some vomiting, associated vomiting, they should report to the
immediately.
doctor.
Perfect.
Further evaluation has to be done.
Got it. So if they have a BP machine at home, they can even check the BP at home to make sure it is not high or things like that to understand. So many people land up going, if they're not too bad, conscious, walking, they go and wait in a doctor's clinic, they go for a couple of days. And then many times I've seen the doctors, some of them, general practitioners, mild stroke must be a ischemic stroke. They even have given aspirin and it expands in size, So the key thing is, how do you diagnose if a patient who comes with a headache or unconsciousness, even if you suspect a stroke, the two, like you said, the two kinds of stroke, ischemic stroke, which is more common at the hemorrhage. What are the tests that you do to find out what kind of stroke patient has had?
So at first, it's a routine that vitals has to be seen.
Correct.
There is a raised BP,
Correct.
pulse rate,
Correct.
all those
Correct.
general
Correct.
checkups has to be done. Of course, many of the patients we see in the emergency ward with some symptoms of whatever we discussed. Then we can go ahead with the CT brain as an initial evaluation for emergency decision making. We can go for a CT brain plain study. So which will give us the basic idea what's happening, whether there is a problem in the brain which is contributing to his headache or something else is happening causing the headache.
Got it.
So next goes with respect to the CT brain reports, we can further evaluate maybe like a CT, some angiograms may also help to differentiate any other causes of bleeds.
Depending if it's an unusual location or a different type of
whether
bleed.
it's a venous infarct or a venous sinus thrombosis or AVM bleeds or any type of secondary ICH.
Correct. It will help us.
It will help us. So basically we have to do a CT brain plane.
So you are saying routinely even an MRI is not required. CT is a good starting point for sure, especially in a stage where MRI is not there.
Yeah.
You can at least quickly do a scan. If hemorrhage is there, MRI is not required. If hemorrhage is not there, then obviously you need MRI to find out whether it's a stroke in window period and things like that. So the commonest symptom I see in many patients who come is fall in bathroom. Bathroom al biddu bandru sir is what they say. And a lot of times, is it really a fall in bathroom that caused this? I'm quite sure you have seen the same.
For a
symptom,
common man, it is that the way they come and explain us. It
and
can
many
be
times the
either of.
doctors also call us and say, sir, patient was fallen in the bathroom, sir.
So it can be either you would have fallen because of some event in the brain, or it could be because of the fall you would have had a problem.
Event in the brain.
So ultimately, a scan should tell us.
Scan will tell us. Yeah. So you're saying it's either an ictus and fall and ictus.
Yeah,
that's what you're saying. It can be either of them, and so we should not neglect one for the other and see what's happening. So now once you do a CT scan and you see that the clot is there, what goes on in your mind? What are the decision making that you do so that you tell our viewers that how does every clot need surgery or every clot needs something? What as a neurosurgeon, what do you say?
All hematomas, all ICH does not require surgery.
Okay.
It all depends on the size. Basically, the first step is supportive care, like controlling the BP.
Correct.
While controlling,
what happens if you don't control the blood pressure?
There can be increased second bleed can happen.
So clot will keep expanding.
Yeah. Clot can rebleed. We many times see two bleeds in the scan.
Correct.
Layered bleeds we can see.
Correct.
So it can happen.
Correct.
And the second thing is when we treat, in the sense control the BP, what we have to take care is manage. We should manage the intracranial pressure and also not compromising the cerebral perfusion pressures. So suddenly BP should not be dropped down. We should maintain a mean arterial pressure of around 100, 110 like that.
You said three important things here now. You use the word ICP.
Yeah.
You use the word perfusion pressure. Third one, you said don't reduce the BP too high.
Yeah.
Sir, one side you are saying high BP, make it low. Other side you said don't make it so low. So can you tell them how these are connected one by one? What does ICP mean?
ICP is intracranial pressure. See, our brain is
intracranial is inside the skull cavity.
Inside the skull. So brain is floating in the CSF inside the skull, which is a rigid structure.
Correct.
So because of the volume plus also the blood supply happening from the heart pumping, there is a pressure environment in the inside the skull. So usually it is 12 to 18 millimeters of mercury.
Okay.
So if it crosses around...
How do you put a BP apparatus on the head to measure? I'm just pulling your leg. So tell her how ICP is measured. You're saying there are 15 to 18 millimeters.
There are many techniques to measure the ICP. Of course, we do it when we manage severe traumatic brain injury or when we have access for the intraventricular CS.
So you put something inside the brain to measure, catheter inside.
Manometer and checked. Sometimes, for example, in normal pressure hydrocephalus evaluation, also we do a lumbar tap and then see the ICP. These are the ways how we can do it. Anyway, so intracranial pressure is a very important factor, and we have very less margin to of around 5 mm to 6 mm.
Why is that? Why is that such critical?
Because brain is in the rigid cavity, rigid structure. So perfusion pressure, they are interrelated. Higher the...
What do you mean by perfusion pressure? Which perfusion are we? Perfusion, can you
cerebral
simplify?
Perfusion,
CPP, and
CPP, cerebral perfusion pressure.
Correct.
So that is relative to the blood pressure and the intracranial pressure.
It is the amount of blood going into the brain, alwa?
Yeah, it should
brain
go
is anta.
Yeah, brain has a autoregulation system as like as another structure in kidney, where with respect to the variation of the BP, blood pressure, the cerebral perfusion pressure, because of the autoregulation, is maintained in a equilibrium. So if the BP falls
that means
drastically,
overcorrection,
the autoregulation fails. If it is too high, also autoregulation fails.
So auto-regulation, madliki, you have to be in that window.
Yeah.
Like how we say high sugar is a problem, low sugar is a problem, high BP is a problem, low BP is a problem.
Yeah.
So reducing the blood pressure, reducing it slowly and maintaining inside whatever you said around the mean arterial pressure of 100 is an important thing.
Important thing. Suddenly, drastically, BP is high, there is a bleed, you cannot... 100 things we should not give and drastically bring the BP. That is not going to help the patient.
It'll harm.
It will harm actually.
Very nice, very nice. I think that's a very important message you have given. On one side, you bring the blood pressure down, not bring it too low. On the other side, you have to maintain the pressure inside the skull cavity at a reasonable level so that the pressure doesn't go high.
Yeah.
So before we go down the path of what next to do, I want to shift gear into your Kasaragod journey. Very few, you see, what of the problem is when people see people like us, they think we're very successful people. We must have studied in convent. We must have gone here. A lot of people don't realize all of us came from middle class, lower middle class backgrounds. We may have come from smaller towns, and we have fought our way through and earned our seat in the house, as what we say. So, can you tell us your childhood journey of what happened and how you got to this level, at least from the childhood of the Kasaragod journey?
See, basically, I'm from a village in Kasaragod. It's called as Paivalike.
Oh, I see. I didn't know this.
Yeah.
Oh.
So there actually, my parents are agriculturists, and their dream was that both the children should be made doctors.
Oh, I see.
I have a younger sister.
Okay.
So
she's also a doctor, alva?
Yeah, she's also a doctor. Yeah. In 1983-84, when I was in a primary school, our village didn't have a English medium school. So I went to up to my 5th standard government school, Kannada medium school was there. So we were going to that school. So
but
then my
father is in Kerala, alva?
Yeah, Kerala.
How it has Kannada medium school?
It's a border district where around 20 to 30% of the people speak Kannada.
Oh, I see.
We have a good number of Kannada medium schools. Even a movie also was done.
How though?
Sarkari Prathamika.
Oh, I see.
So my father went in search of English medium school. Then a nearby town, Vitla. There is a place called Alike. So where there was an English hostel facility.
Oh, in 6th standard hostel go no?
Yeah.
Oh.
So I was put there where it was a CBSE pattern syllabus school for my 6th standard. What happened was that suddenly from my 5th standard even didn't have any education regarding ABCD in English.
Oh, that?
So yeah. So suddenly I was put in CBSE
English medium
where everything was in English. So I could not really cope with whatever happening there, and I lost 1 year in my 6th standard. I failed. So slowly, then I picked up.
Okay.
So
meantime, tough for you.
Yeah.
One hostel, one bit or so, suddenly, in different culture, different,
No, we didn't have any other option.
Correct. That's what you're there. That's what you didn't have an option. See, you didn't have an option. So, karo ya maro, do or die. I can see that clearly in your eyes.
Yeah. So I picked up later on as I went up in the classes. I picked up. So in my 10th standard, I was the 5th guy in the ranking system out of 40. So then in the same institution, I did my +2. So that's how was my school journey. Yeah.
So interesting. So you became doctor because parents wanted you to be.
Definitely.
Did you feel in between Nana Doctor Agbeko, any experience you had as a child?
No, I didn't.
You didn't have a child.
Of course, in Alike, such as Vidya Kendra Alike, we didn't have much extra coaching or tuitions like that. But we had good teachers who motivated us to join professional courses but through CET.
Okay.
So they were guiding us how to apply, which are the colleges, good colleges,
excellent.
which college you have to put first, second, third. So all those things, our wardens, teachers were guiding us.
Very nice.
So in that way, that school has helped many students.
Fantastic.
Yeah.
Fantastic. And what's the name of the school?
It's Satyasai Lokaseva Vrinda Alike.
Oh, Alike.
Yeah.
It's I assume it's still there.
Yeah, still it is there. Still it is there.
Very nice. ಹೋಗಿದ್ಯಾ ವಾಪಸ್ ಸ್ಕೂಲ್
Yeah, several times visited.
They must be very proud of people like you.
definitely.
ಅಲ್ವಾ?
Yeah.
Amazing. ಆಮೇಲೆ where did you do your MBBS from?
Then I joined Government Medical College, Bellari.
Oh,
Bellari, yeah. So it was a place where, very hot place.
I had a cousin who was in Bellari Medical College. She said, Sharan, there are only three weathers here. Hot, hotter, hottest.
Yeah. So our hostels were old jail buildings.
Jail?
Yeah, old jail buildings, yeah.
Rava, Chatra, ಅಲ್ಲೇನು ಭೂತ ಗೀತ ಎಲ್ಲ ನೋಡ್ಲಿಲ್ಲ. Some people say these jails
No,
all
huge roof with the iron
crazy
doors.
No renovation ಹಂಗೆ.
It was slightly converted into with the bathrooms and all those things. They had converted into a hostel type. Most of the departments were also old jail buildings. Yeah, anatomy or microbiology, pharmacology, all those departments.
Amazing.
And many of our, I don't know, because many of our teachers were not liking to get posted there. We had to read ourselves and pass the exam.
ಹೌದಾ? That means you didn't have full-fledged teachers ಅಲ್ಲಿ.
Yeah, we didn't
Government
have
Medical College
government
ಅಲ್ಲಿ.
medical, we didn't
Can you
have.
imagine? See, when was this? 1980, yeah? No, sorry.
93, 94, I joined
94.
my MBBS.
See, we joined MBBS 1986, Sarana, so 8 years difference. Now, or 7 years. Bangalore, Mysore, Hubli, Bellari. They were the only 4 medical colleges of government.
Yeah.
ಅಷ್ಟು ಡಿಫ್ರೆನ್ಸ್ ಇದೆ ನೋಡು. ಬೆಂಗಳೂರು ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ ಬೇರೆ, ಅಲ್ಲದೆ ಬೇರೆ.
Many teachers were preferring Mysore or Bangalore medical colleges. The Hubli and Bellari were the least preferred one. And the Bellari the worst.
I used to hear Bellari was they would want to come back. ಆದಷ್ಟು ಬೇಗ. So you had to actually self-educate yourself, many of the times?
Around 5 to 6 departments didn't have good teachers. Full strength was not there.
Amazing.
In some biochemistry and all, once in a month, our professor is to come and take a class on Sunday and go. At least he did that. Forensic didn't have any teacher.
My goodness.
Yeah.
Guys, you see, here is a guy who did Kannada medium till 5th standard in a small town, village in the border district of Kasaragod in Kannada medium. Then suddenly went to a hostel in 6th standard. And then had a challenge going into CBSE English school. Then fought his way. And then went into a government medical college, government seat ಅಂತ ಸಾಯ್ತಾರೆ. And ಹೋಗ್ಬಿಟ್ಟು he didn't have teachers for subjects. He could have cribbed. He sat and studied. So listen, it's not that ಎಲ್ಲ ಆರಾಮ ಬರ್ತಾರೆ, ಸೀಟ್ ಸಿಕ್ಬಿಟ್ರೆ ಎಲ್ಲ ಬಂದು ಪಾಠ ಮಾಡ್ತಾರೆ, ನೀನು ಆನ್ಸರ್ ಬರ್ಕೊಡ್ತಾರೆ. It's not going to be like that. Every place has its pluses and minuses. You have to fight through your way and do what is going on. Amazing. So you got your MBBS degree. What got you interested in neurosurgery?
If you ask me exactly, I don't have any answer for that.
So, but you went direct 5-year neurosurgery, alva?
Yeah, direct 5 years.
But you were telling me about your interesting, again another set of exams you did. How many exams did you do after MBBS? You were telling me
2000 I finished my house surgeonship. So later I joined. Actually, I wanted to sit and read. That was the trend to sit and read.
ಅದಕ್ಕೆ ನಾವು ಯಾರು MBBS ಡಾಕ್ಟರ್ ಸಿಗೋದಿಲ್ಲ, ಡ್ಯೂಟಿ ಡಾಕ್ಟರ್ ಕೆಲಸ ಮಾಡೋಕ್ಕೆ.
So I went home and prepared my one room for studying. So after 1 or 2 months, my father used to daily come and tell.
What you were telling?
There is one vacancy in that hospital. There is one vacancy in this hospital. It was in our village. It was a little odd for a graduate, that's also a doctor, to sit in the house and study, which the society was not understanding and accepting it. So my father used to get, in the sense,
They used to keep calling and asking you.
in the sense, everyone when he goes, they will ask. Then he didn't have answer to tell, or he could not justify me sitting at home and studying.
Correct.
So then I thought I should not continue like this. So I joined.
Take up his father. At least to make your father happy.
So I joined on a nursing home as a duty doctor. There I worked. It's a cooperative hospital in Kumble. So I was doing night duty. That's from evening 6 to morning 8. So meantime, daytime, we had a study group where 4 to 5 people used to sit and read. So I have written almost entrances. The question you asked, the entrance, maybe around 30 to 40 entrances have written.
30 to 40. ಇವಾಗ ಎಲ್ಲರೂ ಒಂದು ನೀಟ್ ಬರೆಯಕ್ಕೆ ಆಳ್ತಾರಪ್ಪ ಇಲ್ಲಿ.
No. Then we didn't have a single window exam system. So each institution,
its own exam.
Each state had its own exams, and we had to appear for all those.
30 to 40 entrance exam. Imagine, guys.
In 3 years.
In 3 years, he's written 40 exams. He didn't get the first year what he wanted. He tried the second year. He didn't get the second. He tried. This is what is persistence and all about. It's no magic is going to happen. There is no shortcut to hard work. No shortcut to persistence. Then that's where you got into neurosurgery, right?
Yeah.
And where did you do your neurosurgery from?
I did my DNB in Neurosurgery. It's
Correct.
a 5-year course basically.
Correct.
It is from Apollo Hospital, Chennai.
Apollo.
Yeah.
That's a very good hospital. I think they ran a very good program.
Yeah, we had 14 senior neurosurgeons.
14?
14 senior neurosurgeons.
Oh.
They were all, in the sense, very experienced professors from, who means most of them were retired people from Madras Medical College. So daily you used to have around 8 to 10 neurosurgeries.
So you got a lot of experience, exposure and things like that. So you were talking about the clot in the brain, and you measured the clot, and you're looking at whether the pressure is high, ICP, perfusion pressure, and everything else. You also told our viewers that every intercerebral bleed or ICH or hemorrhage does not need surgery. Now, before we go into surgery, people think bleeding ಆಗ್ಬಿಟ್ರೆ continuous ಆಗ್ತಾನೆ ಇದೆ ಅನ್ಕೋತಾರೆ ಬೆಳಿತಾನೆ. Is it really true that it's continuously bleeding, or what exactly?
That is a common question. Once when we counsel, the attender, the first question, did the bleed stop?
Correct.
For which we don't have an answer. Either we should say a lie that nothing is there like that. So I usually tell, see, it's like a scan is like taking a photograph. It only tells the information at that point of time when the scan was done. So I also really don't know whether it's going to rebleed or not, whether the bleeding has stopped or what. What we can discuss is at that point how the scan is, the same what can happen in future in the next
so it can
hours.
bleed stop rather than bleeding. That's what you're trying to say.
Yeah,
no?
yeah.
Correct. Based on the high blood pressure, how well you control it and all other factors. Well said. So once we know that he's had a brain hemorrhage, you shift the patient to ICU. Sometimes conscious patients ask us, why ICU? So what is the risk of expansion, and how long this clot becoming bigger is a risk for a patient?
Sir, there are two aspects. One is risk of rebleed. The second one is risk of raised intracranial pressure.
Correct.
Because of the edema around the hematoma.
Edema and the swelling.
It's a swelling around the brain.
Correct.
Which can harm the adjacent brain and may require modification of our treatment.
Correct.
So it's very important to continuously monitor.
Correct.
So how ECG is being monitored, the same way we can't keep on continuously doing the scans. So we keep checking the BP, pulse rate, and GCS assessment.
What is GCS?
Glasgow Coma Scale.
How do you measure?
The highest score is 15, and lowest score is 3.
Okay.
So
it's a
basically
score for coma, alwa?
Yeah, it's a score for coma. Yeah.
Correct. Coma
And,
is unconsciousness coma.
Unconscious stage or alertness.
Correct. Correct.
So basically with 3 components we assess. One is eye function, one is the speech function, one is the motor functions of the hands and legs.
EVM ಅಂತ ಹೇಳ್ತೀವಿ.
Yeah, EVM.
It's not electronic voting machine, but it is eyes, verbal and motor function.
So which is every hourly monitored by the nursing who is taking care of the patient or the ICU doctors. And also the pupils.
Pupils ಅಂದ್ರೆ ಏನು?
When you see the eye, there is a cornea or the black.
Correct.
So when you put a torch, you can see something blinking like the moving.
True.
So that's called pupil periodically.
Got
So which gives us an alarming sign. Any changes? Yes, this is the time to go for a scan. So that's how we take a decision to do an earlier scan. Or else you would do maybe after 8 hours or 12 hours. You
do a serious
plan
scan.
a repeat
So
scan. Depending upon the first CT scan, you
Correct.
plan the second scan.
Got it. So what you're trying to tell me is, first we do the first scan. We understand from the time of the so-called bleed to the scan what time it has taken. Depending on patient situation, we decide to monitor him and then plan a next scan to serially see whether the clot is becoming bigger, the edema or the swelling is coming in the brain, so that you can alter your treatment based on that.
Yeah.
So it can also give you an indication that a non-surgery patient may become a surgery patient.
Yeah.
Correct. You can go down that path and see.
Yeah.
How was your neurosurgery training? What was the interesting things that you learned? How did you change? ಹೆಂಗಿತ್ತು training? ಕಷ್ಟ ಆಯ್ತಾ? Easy ಇತ್ತಾ?
ನಮ್ಗೆ
Chennai, apart from the heat. But you were used to heat by then, Bellari heat champion ಆಗ್ಬಿಟ್ಟಿದೆ ಅದಕ್ಕೆ heatಗೆ.
Climate was not a factor there because we were in a AC building in the hospital. Only when we come out, maybe after 36 hours or 48 hours of duty, we come out.
Correct.
So climate was not a problem. So we enjoyed actually. ಯಾಕಂತ ಹೇಳಿದ್ರೆ ನಮ್ಮ ಡಿಪಾರ್ಟ್ಮೆಂಟ್ಲಿ ಪ್ರತಿ ವರ್ಷ ಒಂದು 3 ಕ್ಯಾಂಡಿಡೇಟ್ಸ್ ಇರ್ತಿದ್ರು. ಸೊ ಆಸ್ ಎ ಟ್ರೈನಿಂಗ್ ಕ್ಯಾಂಡಿಡೇಟ್ಸ್ 15 people were there, 5-year course. So we used to have good academic activities, daily surgical. So we were involved in all activities. So our teachers were very good, they were very friendly. So
lot of learning also.
Yeah, a lot of learning.
Very nice, very nice. So when did you meet your life partner, Vandana?
Yeah.
Our story hello. I think you had a more exciting story than what we had, I think. I can tell one story here. We had a boy who came in, again another 25-year-old boy who came in with some habits he had. He came with a severe headache, vomiting and mild right side weakness. And he came to the emergency. He was at the time talking and he's reasonably conscious. We did a scan and surprisingly we saw a clot in the brain and not very big. But the blood pressure is very high, 200, 120, normal plus 120, 80. And within the next 3 hours, he went down rapidly. And we did another scan within 4 hours, and the clot had doubled its size. So that also we see, then we had to rush him to OT. You remember that guy, and eventually he did very well. We went to remove the clot. So now in a situation like that, what surgeries, what are the common surgeries that you do if there is a patient? So first is you manage the swelling and first you manage the BP to prevent the clot from becoming bigger. Then you manage the brain swelling, but you said there are some patients who need to go on the ventilator. Why is that? When those decisions, because people get panicky, ventilator hakpitre, patient may not survive and things like that. What is your
decision to assist the patient for breathing or to protect the airway, basically to prevent. Some people may be breathing themselves, but they may not have a good cough reflex, in the sense the ability to cough and avoid aspirations
into the lungs.
And
cause
such
pneumonia.
people may be like GCS of 8 or like that.
Correct.
So many times our ICU doctors will tell, patient is breathing, maintaining saturation, it's okay, there is no indication. But I always insist, he may aspirate.
Correct.
Suddenly he may deteriorate. So that time we may have to intubate and then connect to the ventilator. The other thing is when there is no good effort for breathing because of the brain damage, then we'll have to connect on the ventilator.
So what Dr. KP is saying, very importantly, if there are any medical students listening, or if there are any junior doctors listening, or even intensive care guys who are not exposed to neurocritical care, because neurocritical care is a very important subspecialty inside critical care, saturation dropping is not the only indication for putting the patient on ventilator. In neuro patients, the moment the coma score becomes 8 or lesser, their ability to protect their airway becomes lesser. And ಇವಾಗ ನಾವು ಒಂದ್ಸಲ ಊಟ ಮಾಡಿದಾಗ choke ಆಗತ್ತೀವಿ, we start ದೆತ್ತಿಗೆ ಹತ್ತಿದೆ and we do like this. That means the food is going into the windpipe instead of the food pipe. If that happens and he cannot cough out, it goes inside and causes pneumonia and patients can die because of that. That's what he's trying to say. And to prevent that, we put in a tube to protect the airway and then also put on the ventilator to make sure we ventilate to reduce the brain swelling. Well said.
It also helps in controlling means we can sedate the patient, make him calm. Also helps in reducing the intracranial pressure.
Correct.
So treatment wise also it helps.
It helps. Absolutely. So neurosurgery is one of the, I always keep telling the ICU, young doctors in the ICU and who work with us, neuro probably is the only place, neurocritical care, where we talk about an elective ventilation rather than an emergency. Everywhere else we talk about, emergency ventilation. So we do elective ventilation to protect the brain many times, from what is going on. Good. So you have taken the blood pressure control, you have, brain swelling, you put the patient on ventilator, yet things are not okay. His GCS, coma score is coming down, his pupil is having a problem. You do a scan, the clot has become bigger, the pressure seems to be very high. How do you decide how high is the pressure on a CT scan? Because you said unless you put the pressure inside, you will not know. Are there any indirect indicators that the pressure inside the brain is high on a CT scan?
Basically,
Like how do you decide like midline shift, things like
yeah,
that?
basically, the guidance is from the CT scan findings.
Correct.
So,
correct.
for example, a hematoma in the cerebellum,
Mm.
posterior for the cerebellum,
Mm.
if it is causing distortion of the brainstem or
Correct.
compression of the fourth ventricle
Correct.
and causing a hydrocephalus,
Correct.
so that needs early evacuation.
So hydrocephalus is what? Can you explain to our audience what is
the brain is floating in CSF.
correct?
So the
Cerebrospinal fluid.
cerebrospinal fluid.
Mm.
There is a cavity inside the brain called ventricular system.
Inside the brain.
Inside the brain.
Hmm.
So where the CSF is produced.
Okay. This is normal present for everybody.
At any given point of time, the CSF volume may be around 100 to 150 ml inside the skull.
Hmm.
Like our saliva or our
Gastric juice,
urine or gastric juice, it keeps on producing. Per day around 600 to 700 ml of CSF is produced. The balance, whatever around 400 ml, gets circulated and gets absorbed.
Correct.
So this circulation keeps happening through the ventricle, and the ventricle has some holes, foramens called Luschka and Magendie, from which it comes out and comes to the subarachnoid space.
Correct.
That is the surface of the brain and gets absorbed.
Correct.
So wherever there is a block,
The outlet
blocks or malabsorptions because of the bleed, especially in the circumstance of bleed. So the volume of water I had told as 150 or 100 ml may become 200 ml or 300 ml.
Because it's coming in but not going out. Brain.
And it raises the intracranial pressure.
Got it.
So this is called hydrocephalus,
Got it.
which needs emergency.
So what did you do? So you're
intervention.
speaking about a cerebellar hematoma which expanded, blocked the fourth ventricle, caused hydrocephalus.
Yeah.
So that's an indication for surgery.
Yeah.
So what kind of surgery do you do in such patients? Where is the cerebellum? Cerebellum is the back
Cerebellum is in the back,
back of the
region,
brain.
behind just above the hairline in the neck collar area.
Correct.
Huh?
So what would you do in a surgery like that, in that area? Of the
In
brain?
such a situation, we have to do two site surgeries. One is
okay.
we have to remove the bone on the surface of the that hematoma area and evacuate the hematoma. Good.
So remove the clot.
The second one is the second surgery. We have to put a external ventricular drainage (EVD), a small elastic tube.
Where do you do that? Why do you do that?
In the skull here above.
Okay.
So to drain the CSF.
The fluid that is blocked.
The fluid,
so you want to bring it out. Got it.
Both the surgeries mainly helps in reducing the intracranial pressure.
The pressure inside.
Yeah.
So prevents the
basic
further
work
brain.
of neurosurgeon is to maintain a good pressure in the brain.
Correct. Perfusion and
Perfusion and pressure. So this is all we are struggling to do with the patient.
Perfect. And allow the brain to heal.
Yeah. The injured brain will take its own time to heal.
Very
then comes a rehab program. All those
very
things
nicely
come.
said. Very nicely said. So that means the damaged brain will take its time to heal.
Yeah.
The additional risk to life and the quality of life depends on the additional brain damage because of raised pressure and the perfusion issue. So you remove the clot, reduce pressure, and remove the water, whatever it is, and maintain the environment for healing to happen.
Yeah.
So my next automatic question, which is on behalf of all patients. The moment you remove the clot, will patient wake up? Will he become conscious? Will he talk?
No.
Why is that? Why is that not happening?
Surgery is basically to manage the pressure in the brain.
Correct. Not to repair the damage.
Not to repair. We cannot repair. There's always, I tell when during my counseling time, I say, I remove the blood clot. But during the bleed, there is a split of brain and damage.
Correct.
And you can just see the opposite side of the brain. The right side, if there is a hematoma in the left side, you see the right side brain. This should have been like this. So
you show a comparison.
Yeah, I show the comparison for better understanding from by common people.
Perfect.
So there is a damage of the brain, which we cannot repair by surgical procedures. Over a period of time, it should
heal by
neuroplasticity, rehab. Slowly, it should over a period of time, it should improve.
And it's not a guarantee also that
it is not a guarantee.
It's not a guarantee.
Yeah.
And if a patient is unconscious, Glasgow coma score is less, is there a risk to their life? Just by in a sense, will everybody survive or some patients may not survive?
See, by literature wise, every ICH patient, the 30-day mortality is 45%.
45%, no? Correct.
Literature wise, it's a 45% in a 30-day mortality
So what Dr.
range.
KP is trying to say very simply is, if a patient, anybody known to you as an ICH, in the 30 days post ICH, the chance, if 100 patients come in, 45 patients die.
Yeah.
45 patients die. It is a very high number. Now you understand, guys, it's not stupid advice we are giving you. Please take your BP medicines regularly and check your blood pressure. It is the easiest, simplest thing to do. You can have a BP machine yourself at home and check it 10 times a day if you want. It takes less than 1 minute to do. So 45% is a serious mortality.
Yeah.
So if they survive, 55%, they become normal?
No.
Not necessary.
It all depends on the site of
Correct.
location.
So it's not
of
necessary.
Yeah, it's not necessary.
It's not necessary.
Saving life is different. Quality of life is different.
Well said, well said.
What
So,
we try in the initial stage is saving life.
saving life.
Once he is out of ICU, then we look at the improving the quality of life.
Well, perfectly well.
Yeah.
So then how he gets better, Kanbirtana, Gnanabarata, does he open his eyes? Does he get consciousness? Is he going to talk? Is he going to walk?
Yeah.
There's so many things that go on in the process.
Yeah.
Before we go down that path, what is the average time that the patients remain in ICU in let us say, in a hematoma like this, with or without surgery? Is it 2-3 days or?
No,
or
it may be
ventilator?
a minimum of 5 to 7 days. It all depends again the extent of damage, the other comorbidities like sugar or any aspirations during the transportation of the
Correct.
patient from the home site to the
ABC.
hospital, airway protection, all the many factors
Correct.
come into picture.
And sometimes
So-
it can be even a month.
Yeah, sometimes even a month. They may
Agree.
require a tracheostomy, prolonged ventilation,
Correct.
multiple infections may need
Correct.
adequate antimicrobial
Antibiotic.
therapies.
So what you're trying to say is, just an operation is not the be all end all and the solution and everything is done. It's
No,
not like that.
no.
There's so many other things also has to be taken care of, looked at, anticipated, treated.
Surgery is only a part of the treatment. Maybe
Correct.
I usually say surgery is only 10% of the treatment. Next 90% is still remaining. You have to wait for that.
So
Many
please-
people think once surgery is done, our
Exact.
responsibility is over.
Correct.
Tomorrow it's fine. You should be
Correct,
okay.
correct. And that's
That's
what I'm
not
trying
the
to.
truth.
Yes, that's what I'm trying to make you understand.
Yeah.
See, guys, 5 to 7 days in the ICU, sometimes maybe a month in the ICU. All of you know, ICU costs per day vary anywhere between 15,000 rupees per day to 1 lakh rupees per day, depending on which hospital you're going to go into. Charitable hospital or a government hospital or in a high corporate hospital. So you can imagine that many rupees per day into that many days. So how many of you have made so much of insurance? Think about it. You don't want to make medical insurance. You don't want to have adequate insurance. On third time, they don't want to take the tablets. They don't want to check. KP, they're on a suicide mission, alva. If they do all of these things, and then they expect everybody else to work for them, it just doesn't make any sense. We have one fellow lying in the hospital just now. He came in last week, and this guy, Mondo, he doesn't want to take BP medicine. Every day fighting with his wife and son. They're trying to make him to take. He doesn't know. He's a very intelligent fellow, business fellow. He's got a left side thalamic bleed, right side hemiparesis. Luckily or unluckily, he's talking, though he's got a weakness. And Mondo, I want to go home. He's not in moving. Then finally, I had to fire him. I said, do you know what has happened? You are in this raise your right hand. You can't move your leg. You can't. Do you realize that you have gone on a suicide mission and harmed yourself? So you have to now be a good boy and just get better. Halwa, they just don't understand.
That's why I usually tell time is health and wealth.
That's what you have written.
Yeah.
Yes. So can you explain what made you write this motto?
See, basically we have to take care of ourselves. We have to give time for ourselves. We are
Correct.
into profession. So if we keep on doing the daily things, it's just day-to-day activities.
Correct.
So yeah, when we continue, we will be very happy doing it. But one day when we sit, then we become lonely. Oh, I have not done anything. Because
Other
it's like going to school. Keep on, daily you go to school and do the homework. That's what happens.
Correct.
So as time passes, you should also think of your own other activities,
Personal health, personal life.
So which will definitely contribute in your health, also wealth building and all those things. Second, in the context of patient treatment, many times we in an emergency situation we call the relatives and explain them, say this is a problem, I need to rush him to the surgery. It's very important to have an emergency surgery. So many people don't understand. There are,
Despite of explanation.
yeah, around 5% of the people think this doctor is not fine. He's trying to persuade me, ask for going for a surgery. He has a different motive. Yeah, he's hurrying. So
Trying to make money.
Trying to make money.
I have heard all this.
He's extorting. Is ಹೆಲ್ತ್ ಅಂಡ್ ವೆಲ್ತ್ ಅಂತ ಹೇಳಿ. ಈಗ ಟ್ರೀಟ್ಮೆಂಟ್ ಸಂಬಂಧಪಟ್ಟು ನಾವು ಈ ಕಂಟೆಕ್ಸ್ಟಲ್ಲಿ ಮಾತಾಡಬೇಕು ಅಂತ ಹೇಳಿದ್ರೆ, ಫಾರ್ ಎಕ್ಸಾಂಪಲ್ ಒಂದು ಸರ್ಜರಿ ಅವಶ್ಯಕತೆ ಇದೆ ಪೇಷಂಟಿಗೆ ಅಂತ ಹೇಳಿದಾಗ ನಾವು ಪೇಷಂಟ್ ರಿಲೇಟಿವ್ಸ್ ಕರೆದು ಎಲ್ಲ ಎಕ್ಸ್ಪ್ಲನೇಷನ್ ಮಾಡ್ತೀವಿ. ಹೀಗಿದೆ, ಅರ್ಜೆಂಟ್ ಇದೆ, ಸೊ ಆದಷ್ಟು ಬೇಗ ಸರ್ಜರಿ ಮಾಡಬೇಕು, ರಿಸ್ಕ್ ಇದೆ, ಡ್ಯಾಮೇಜ್ ಜಾಸ್ತಿ ಆಗುವ ಚಾನ್ಸಸ್ ಇರ್ತದೆ ಡಿಲೇ ಆದಾಗೆ ಅಂತ ಹೇಳ್ತೀವಿ. ಸೊ ಮೆನಿ ಫ್ಯಾಮಿಲೀಸ್ ಏನು ಮಾಡ್ತಾರೆ ಅಂತ ಹೇಳಿದ್ರೆ, ನಾವು ಅವ್ರನ್ನ ಕೇಳಬೇಕು, ಇವ್ರನ್ನ ಕೇಳಬೇಕು ಅಂತ ಹೇಳುವಂಥ ಒಂದು ಊರಿಂದ ಬರಬೇಕು, ಅವ್ನು ಬಸ್ಸಲ್ಲಿ ಬರ್ತಾ ಇದ್ದಾನೆ, ಅವ್ನು ಕೇಳಬೇಕು. ಅವರ ಫ್ಯಾಮಿಲಿ ಸಿಚುವೇಶನ್ ನಮಗೆ ಗೊತ್ತಿರಲ್ಲ, ಹೊಸಬ್ರು ಅವರು.
ಬಟ್ ಎಲ್ಲರ ಹತ್ರ ಫೋನ್ ಇದೆ, ಅವಾಗ ಫೋನಲ್ಲಿ ಕೇಳಬೇಕು, ಅವ್ನು ಬರಬೇಕು 5 hour 6 hour ಕೂತ್ಕೊತಾರೆ.
ಇನ್ನು ಕೆಲವರೊಂದು 5% ಜನರು ಡಾಕ್ಟರ್ ದುಡ್ಡು ಮಾಡೋಕ್ಕೋಸ್ಕರ ಏನೋ ನಮ್ಮನ್ನು ಪುಷ್ ಮಾಡ್ತಾವ್ರೆ ಸರ್ಜರಿಗೆ. ಇವ್ರ ಹಿಂದೆ ಏನೋ ಒಂದು ಬೇರೆ ಒಂದು ಮನಸ್ಸು ಇದೆ. ಕೆಲವೊಮ್ಮೆ ನಾವು ಫೈನಾನ್ಸಸ್ ನಾವು ಪೇಷಂಟ್ ಜೊತೆ ಮಾತಾಡಬೇಕಾಗುತ್ತೆ. ಖರ್ಚು ವೆಚ್ಚಗಳು ಅವರಿಗೆ ಎಲ್ಲ ಕಂಪ್ಲೀಟ್ ಟ್ರೀಟ್ಮೆಂಟ್ ಮಾಡುವ ಒಂದು ಸಂದರ್ಭಗಳು ಇದೆಯಾ ಇಲ್ವೋ ನಮ್ಗೆ ಗೊತ್ತಿರಲ್ಲ, ಅವರ ಫೈನಾನ್ಸ್ ಬ್ಯಾಕ್ ಗ್ರೌಂಡ್ ನಮ್ಗೆ ಗೊತ್ತಿರಲ್ಲ. ಸೊ ಹೇಳುವಂಥದ್ದು ನಮ್ಮ ಕರ್ತವ್ಯ. ಹಾಗಾಗಿ ಆ ಟೈಮಲ್ಲಿ ಕನ್ಫ್ಯೂಷನ್ಸ್ ಸ್ಟಾರ್ಟ್ ಆಗುತ್ತೆ ಅವ್ರ ಮನಸ್ಸಲ್ಲಿ. ಸೊ ಏನಾಗುತ್ತೆ, ಅವರು ಕನ್ಸೆಂಟ್ ಕೊಡೋಕ್ಕೆ ಡಿಲೇ ಮಾಡ್ತಾ ಇರ್ತಾರೆ. ಕನ್ಸೆಂಟ್ ಕೊಟ್ಟಿಲ್ಲ
ಸರ್ಜರಿ ಶುಡ್ ಐ ಗೆಟ್ ಸರ್ಜರಿ, ನಾಟ್ ಗೆಟ್ ಸರ್ಜರಿ, ಕರೆಕ್ಟ್ ಅರ್ಥ ಆಯ್ತು.
ಸೊ ಆವಾಗ ಸರ್ಜರಿ ಡಿಲೇ ಆಗ್ತಾ ಇರುತ್ತೆ. ಸರ್ಜರಿ ಡಿಲೇ ಆದಂಗೆ ಬ್ರೈನಲ್ಲಿ ಡ್ಯಾಮೇಜಸ್ ಜಾಸ್ತಿ ಆಗ್ತದೆ. ವಾಟ್ ವಿ ಕಾಲ್ ಸೆಕೆಂಡರಿ ಡ್ಯಾಮೇಜಸ್. ಏನು ಅವನು ಆಸ್ಪತ್ರೆ ಬಂದಿರೋದು ಮೆದುಳಲ್ಲಿ ರಕ್ತಸ್ರಾವ ಆಗಿ ಬಂದಿರ್ತಾನೆ, ಬಟ್ ಅದರಿಂದಾಗಿ ಬೇರೆ ಪ್ರಾಬ್ಲಮ್ಗಳು, ಸೆಕೆಂಡರಿ ಡ್ಯಾಮೇಜಸ್,
ಬ್ರೈನ್ ಪ್ರೆಷರ್ ಎಲ್ಲ ಸೇರಿ
ಪ್ರೆಷರ್ ಜಾಸ್ತಿ ಆಗುವಂಥದ್ದು, ಇಂಥದ್ದೆಲ್ಲ ಪ್ರಾಬ್ಲಮ್ಸ್ ಜಾಸ್ತಿ ಆಗಿ ಹೋಗಿ ಜೀವ ಹೋಗುವ ಒಂದು ಸಂದರ್ಭಗಳು ಜಾಸ್ತಿ ಇರುತ್ತೆ. ಸೊ ಟೈಮ್ ಅಂತ ಹೇಳುವಂಥದ್ದು ಹೆಲ್ತ್ ಪ್ಲಸ್ ಅದರಿಂದಾಗಿ ಡಿಲೇ ಆಯಿತು, ಅದರಿಂದಾಗಿ ಪೇಷಂಟ್ ರಿಕವರಿ ಡ್ಯಾಮೇಜ್ ಜಾಸ್ತಿ ಆಗ್ಬಿಟ್ಟು ರಿಕವರಿ ಆಗಲಿಲ್ಲ ಅಂದರೆ ಅಷ್ಟೇ ಅವನಿಗೆ ರಿಕವರಿ ಸ್ಟೇಜಲ್ಲಿ ಪ್ರೊಲಾಂಗ್ಡ್ ಐಸಿಯು ಸ್ಟೇ, ಹಾಸ್ಪಿಟಲ್ ಬಿಲ್ ಜಾಸ್ತಿ ಆಗುತ್ತೆ, ಕ್ವಾಲಿಟಿ ಆಫ್ ಲೈಫ್ ಚೆನ್ನಾಗಿರಲ್ಲ. ಸೊ ಅಲ್ಲಿ ವೆಲ್ತ್ ಲಾಸ್ ಆಗುತ್ತೆ.
ವೆರಿ ವೆಲ್ ಸರ್. ಒಂದ್ಸಲ 5 ದಿವಸ ಐಸು ಬದಲಾಗಿ 50 ದಿವಸ ಆಗುತ್ತೆ, 30 ದಿವಸ ಆಗುತ್ತೆ, ಕರೆಕ್ಟ್ ಅಲ್ವಾ? ಫಾರ್ ಅ ಡಿಲೇ ಆಫ್ ಕಪಲ್ ಆಫ್ ಅವರ್ಸ್, 2-3 hours we have seen sometimes, because time is brain. ಅದಕ್ಕೆ ನಾವು ಹೇಳ್ತಾ ಇರೋದು
ಬರೀ ಆಸ್ಪತ್ರೆ ಬಿಲ್ ಅಲ್ಲಿ ಕ್ವಾಲಿಟಿ ಆಫ್ ಲೈಫ್. ನಾಳೆ ಅವನ ಮನೆಗೆ ಹೋದ್ಮೇಲೆ ಅವನು ಅಟ್ ಲೀಸ್ಟ್ ಅವನ್ ಕೆಲಸ ಮಾಡ್ಬೇಕು, ಡಿಪೆಂಡೆಂಟ್ ಇರಬಾರ್ದು, ಅಥವಾ ಅಟ್ ಲೀಸ್ಟ್ ಜಾಬ್ಗೆ ಹೋಗ್ಬಿಟ್ಟು ಒಂದು ಲೈವ್ಲಿಹುಡ್ ಮಾಡಬೇಕು. ಸೊ ಇದೆಲ್ಲ ಡಿಲೇ ಆಗ್ಬಿಟ್ಟು 1 ವರ್ಷ 2 ವರ್ಷ ಡಿಲೇ ಆಯ್ತು ಅಂದ್ರೆ ಇಟ್ಸ್ ಎ ಲಾಸ್. ಕರೆಕ್ಟ್. ಇಫ್ ಯು ಕ್ಯಾಲ್ಕುಲೇಟ್, ಇಫ್ ಇಟ್ ಇಸ್
ಅಬ್ಸಲ್ಯೂಟ್ಲಿ ಕರೆಕ್ಟ್ ಲಾಸ್. ಸೊ ವಾಟ್ ಕುಡ್ ಹ್ಯಾವ್ ರಿಕವರ್? ಫಸ್ಟ್ ಆಫ್ ಆಲ್, ರಿಕವರ್ ಆಗೋ ಪೇಷಂಟ್ ರಿಕವರ್ ಆಗದೆ ಇರ್ಬೋದು, ಫುಲ್ ರಿಕವರ್ ಆಗೋ ಪೇಷಂಟ್ ಅರ್ಧ ರಿಕವರ್ ಆಗ್ಬೋದು, ಕೆಲ್ಸಕ್ಕೆ ಹೋಗ್ಬೋದಾಗಿತ್ತ ಪೇಷಂಟ್ ಹೋಗದೆ ಇರ್ಬೋದು. ಸೊ ಲಾಟ್ ಆಫ್ ಥಿಂಗ್ಸ್ ಕ್ಯಾನ್ ಹ್ಯಾಪನ್ ವಿತ್ ಅ ಫ್ಯೂ ಅವರ್ಸ್ ಅಲ್ವಾ ಆಫ್ ಡಿಲೇ. ಸೊ ವೆರಿ ವ್ಯಾಲ್ಯೂಬಲ್ ಪಾಯಿಂಟ್ಸ್. ನೆಕ್ಸ್ಟ್ ಥಿಂಗ್ ಹಿ ಇಸ್ ಸೇಯಿಂಗ್ ಇಸ್, ಡೋಂಟ್ ವೇಟ್ ಫಾರ್ ಇವ್ರು ಬರಬೇಕು ಅವ್ರು ಬರಬೇಕು. ಅರ್ಥ ಮಾಡ್ಕೊಳ್ಳಿ, ಸಮ್ಟೈಮ್ಸ್ ಎಮರ್ಜೆನ್ಸಿ ಇಸ್ ಎಮರ್ಜೆನ್ಸಿ ಅಟ್ ದ ಎಂಡ್ ಆಫ್ ದ ಡೇ.
ಟ್ರಸ್ಟ್ ಆನ್ ದ ಡಾಕ್ಟರ್.
ಟ್ರಸ್ಟ್. ಇವಾಗ ಹಾರ್ಟ್ ಅಟ್ಯಾಕ್ ಆಗ್ತಾ ಇದ್ರೆ, ಇಲ್ಲ ಅವ್ರು ಬರಲಿ ನಾಳೆ ಬೆಳಗ್ಗೆ ತನಕ ಕಾಯಿಲಿ, ಹಾರ್ಟ್ ವೇಟ್ ಮಾಡುತ್ತೆ, ಯಾರು ವೇಟ್ ಮಾಡಲ್ಲ. ಸೊ ಸೇಮ್ ಅರ್ಜೆನ್ಸಿ ನೀವು ಹಾರ್ಟ್ ಕೊಡೋ ಅರ್ಜೆನ್ಸಿ ಸೇಮ್ ಬ್ರೈನ್ಗೂ ಕೊಡ್ಬೇಕು. ಆ ಅರ್ಜೆನ್ಸಿ ಇಲ್ಲ ಕೆಪಿ. ತುಂಬಾ ಜನಕ್ಕೆ ಹಾರ್ಟ್ ಅಂತ ಮಾಡಿಸ್ಬಿಡ್ತಾರೆ, ಬ್ರೈನ್ ಅಂದ್ರೆ ಸ್ವಲ್ಪ ಹಿಂಗ್ ಮಾಡೋಣ ಹಂಗ್ ಮಾಡೋಣ ಯೋಚನೆ ಮಾಡಿ ಮಾಡ್ತಾರೆ. ದಟ್ ಇಸ್ ಅ ಬಿಗ್ ಪ್ರಾಬ್ಲಮ್ ಫಾರ್ ಅ ಲಾಟ್ ಆಫ್ ಪೀಪಲ್ ಅಲ್ವಾ? ಐ ಆಮ್ ಕ್ವೈಟ್ ಶೂರ್ ಯು ಆಲ್ಸೋ ಎಕ್ಸ್ಪೀರಿಯನ್ಸ್ ದ ಸೇಮ್ ಥಿಂಗ್. ಇಟ್ಸ್ ವೆರಿ ಇಂಟ್ರೆಸ್ಟಿಂಗ್. ಸೊ ದಟ್ಸ್ ಒನ್ ಆಸ್ಪೆಕ್ಟ್ ಆಫ್ ಇಟ್. ಸೊ ICU ಮಾಡ್ತೀವಿ, ಇದು ಸೆರೆಬೆಲ್ಲರ್ ಆಯ್ತು. ವಾಟ್ ಅಬೌಟ್ ದಿ ಸರ್ಜರಿ ಆನ್ ದ ಟಾಪ್ ಆಫ್ ದ ಬ್ರೈನ್? ಇಲ್ಲೇನು ಸಪೋಸ್ ಯಾವ ಲೋಬಾರ್ ಹೆಮಟೋಮಾ ಆಗಲಿ, ಒನ್ ಆಫ್ ದ ಲೋಬ್ಸ್ ಅಲ್ಲಿ ಆಗಲಿ, and large hematoma, what do you do in surgery for such patients?
In young patient, and if the relatively large blood clot with the pressure effects are seen in the CT scan, and
midline shift 8 mm,
midline shift more than 5 mm, and hydrocephalus if there is intraventricular extension, and there is a drastically deteriorating clinically
ಡೌನ್ ಆಗ್ತಾ
ಇದ್ರೆ then he needs that hematoma needs evacuation.
ಅದು ಸರ್ಜರಿ ಬೇಕಾಗುತ್ತೆ.
ಸೊ
ಎಂತ ಸರ್ಜರಿ ಮಾಡ್ತೀಯ ಅಲ್ಲಿ?
ಸೊ ಕೈಯಷ್ಟು ಅಗಲಕ್ಕೆ ಬೋನ್ ಚಿಪ್ ನಾವು ಆ ಸೈಡ್ ಇಂದ ಕಟ್ ಮಾಡ್ಬಿಟ್ಟು ಬ್ರೈನ್ ಆಕ್ಸೆಸ್ ಮಾಡ್ತೀವಿ. ಬ್ರೈನ್ ಅಲ್ಲಿ ಒಂದು ಬ್ಲಡ್ ಕ್ಲಾಟ್ ರೀಚ್ ಆಗಕ್ಕೆ ಒಂದು ಹೋಲ್ ತರ ಮಾಡ್ಬಿಟ್ಟು ಆ ಬ್ಲಡ್ ಕ್ಲಾಟ್ ಎಷ್ಟಾಗುತ್ತೆ ಅಷ್ಟು ತೆಗಿತೇವೆ, ಎಲ್ಲ ತೆಗಿಯಲ್ಲ, ಯಾಕಂದ್ರೆ ಬೇಕಾಗಿಲ್ಲ. ಪ್ಲಸ್ ದೇರ್ ಇಸ್ ಅ ಚಾನ್ಸ್ ಆಫ್ ರೀಬ್ಲೀಡ್ ಆಲ್ಸೋ ಇನ್ ದ ರಾ ಏರಿಯಾ. ಹಾಗಾಗಿ ಒಂದು 80 to 70% ಬ್ಲಡ್ ಕ್ಲಾಟ್ ತೆಗಿತೇವೆ. ಸೊ ಆ ಚಿಪ್ ಆಸ್ ಪರ್ ದಿ ಸಿಚುವೇಶನ್ ಈಚ್ ಇಂಡಿವಿಜುವಲ್ ಇಸ್ ಡಿಫ್ರೆಂಟ್. ಸೊ ನಮ್ಗೆ ಆಪರೇಷನ್ ಮಾಡ್ಬೇಕಾದ್ರೆ ಪ್ರೆಷರ್ ಎಲ್ಲ ಕಂಟ್ರೋಲ್ ಬಂದಿದೆ, ಚೆನ್ನಾಗಿ ಬಂದಿದೆ, ದೇರ್ ಇಸ್ ಏನು ವಾಪಸ್ಸು ಪ್ರೆಷರ್ ಜಾಸ್ತಿ ಆಗುವ ಸಂದರ್ಭಗಳು ಇಲ್ಲ ಅಂದರೆ ಆ ಬೋನನ್ನು ಮೆನಿ ಟೈಮ್ಸ್ ವಿ ಕ್ಯಾನ್ ಕೀಪ್ ಇಟ್ ಬ್ಯಾಕ್ ಇನ್ ದ ಸೇಮ್ ಪೊಸಿಷನ್. ಸೊ ಟು ಬಿ ಸೇಫರ್ ಹೊಟ್ಟೆಯಲ್ಲಿ ನಾವು ಫ್ಯೂಚರ್ ಯೂಸಿಗೆ ಅದನ್ನು ಬೇರೆ ಕಡೆಗೆ ಇಡ್ಬೋದು. ಹಲವು ರೀತಿಯಲ್ಲಿ ಹಲವು ಡಾಕ್ಟರ್ಸ್ ಮಾಡ್ತಾರೆ. ನಾನು ಅದನ್ನು ಯೂಶಲಿ ಇಲ್ಲಿ ಆಂಬ್ಲಿಕಸ್ ಹತ್ರ ಒಂದು ಸ್ಕಿನ್ ಕೆಳಗಡೆ ಪೌಚ್ ಮಾಡ್ಬಿಟ್ಟು ಅಲ್ಲಿ ಸ್ಟೋರ್ ಮಾಡ್ಬಿಡ್ತೇನೆ.
ಯಾಕಂದ್ರೆ ಮೆದುಳು ಹೊರಗೆ ಬರ್ಬೇಕು ಅಲ್ವಾ, ಹೊರಗೆ ಬಂದಾಗ ಸೆಂಟ್ರಲ್ ಬ್ರೈನ್ ಮೇಲೆ ಪ್ರೆಷರ್ ಆದ್ರೆ ಜೀವಕ್ಕೆ ಅಪಾಯ ಆಗುತ್ತೆ. ಅದನ್ನು ಉಳಿಸ್ಲಿಕ್ಕೆ ನಾವು ಅಗೇನ್ ಸರ್ಜರಿ ಜೀವ ಉಳಿಸಕ್ ಮಾಡ್ತಾ ಇರೋದು. ಹೌದು ಅಗೇನ್ ಲೈಫ್ ಸೇವಿಂಗ್. ಸೊ ಅಟ್ ಎಂಡ್ ಆಫ್ ದ ಡೇ ಅದು ಬ್ರೈನ್ ತಾನಾಗೆ ವಾಸಿ ಆಗ್ಬೇಕು. ಬ್ರೈನ್ ವಾಸಿ ಆಗ್ಲಿಕ್ಕೆ ಕಾಲು ಊತ ಬಂದ್ಬಿಟ್ರೆ ಪ್ರೆಷರ್ ಅದೇ ತರನೇ ಮೆದುಳಲ್ಲಾದಾಗ ಚಿಪ್ ತೆಗೆದ್ಬಿಟ್ಟು ಹೊಟ್ಟೆಲಿ ಇಟ್ಬಿಡ್ತೀವಿ. ಹೊಟ್ಟೆ ಅಂದ್ರೆ ಹೊಟ್ಟೆ ಇದರಲ್ಲಿ ಚರ್ಮಲ್ಲಿ ಇರ್ತೀವಿ, ಒಂದು ಪಾಕೆಟ್ ತರ ಮಾಡಿ. ಆ್ಯಂಡ್ ದಿ ಬ್ರೈನ್ ಹೀಲ್ಸ್ ಹೊಟ್ಟೆ 6 to 8 weeks ಸ್ಲೋ ಒಳಗೆ ಹೋಗುತ್ತೆ. ಒಳಗೆ ಹೋದ್ಮೇಲೆ ವಾಪಸ್ ತೆಗೆದು ವಾಪಸ್ ಇಡಬೇಕು. ದಟ್ಸ್ ವಾಟ್ ವಿ ಡು. ಸೊ ಇವಾಗ ಸೆಂಟ್ರಲ್ ಬ್ರೈನ್ಲಿ ಹೈಡ್ರೋಕೆಫಲಸ್ ಅದು ಒಳಗೆ ಬ್ಲಡ್ ಹೋಗೋದ್ಬಿಟ್ಟು ಯು ಬಿನ್ ಮೇಕಿಂಗ್ ಆಲ್ ದೋಸ್ ಕಾಮೆಂಟ್ಸ್. ಸೊ ಇವಾಗ ಸಪೋಸ್ ಅದು ಸೆಂಟ್ರಲ್ ಬ್ರೈನ್ ವೆಂಟ್ರಿಕಲ್ ಒಳಗೆ ರಕ್ತ ಹೋಗ್ಬಿಟ್ಟಿದ್ರೆ ಪ್ರೈಮರಿ ಇಂಟ್ರಾವೆಂಟ್ರಿಕ್ಯುಲರ್ ಹೆಮರೇಜ್ ಅಂತ ಹೇಳ್ತೀವಿ. ಪ್ರಿಡಾಮಿನೆಂಟ್ ಇಂಟ್ರಾವೆಂಟ್ರಿಕ್ಯುಲರ್ ಹೆಮರೇಜ್ ಅಂತ ಇದ್ರೆ ಕ್ಲಾಟ್ ತೆಗೆದು ಬರೀ ಇದು ತೆಗಿಬೇಕಂದ್ರೆ ಅವಾಗ ಇಬಿಡಿ ಇದು ಅವಾಗ ಒಳಗೆ ಟ್ಯೂಬ್ ಹಾಕ್ತೀವಿ. ಟ್ಯೂಬ್ ಹಾಕಿ ವಿ ಕ್ಯಾನ್ ಪುಟ್ ಸಮ್ ಮೆಡಿಸಿನ್ ಇನ್ಸೈಡ್ ಅಲ್ಲ. ಕ್ಯಾನ್ ಯು ಟೆಲ್ ಅವರ್ ವ್ಯೂವರ್ಸ್ ಅಬೌಟ್ ದಟ್? ಹೌದು,
ಒಂದು ಹಾರ್ಟ್ ಅಲ್ಲಿ ನಮಗೆ ಕ್ಲಾಟ್ ಇದ್ರೆ ಏನು ಇಂಜೆಕ್ಷನ್ ಕೊಡ್ತಾರೆ. ಅದೇ ರೀತಿ ಯೂರೋಕೈನೇಸ್, ಸ್ಟ್ರೆಪ್ಟೋಕೈನೇಸ್ ಇಂಜೆಕ್ಷನ್ಸ್ ನಾವು ಆ ಟ್ಯೂಬ್ ಅಲ್ಲಿ ಅದಕ್ಕೆ ಇಂಜೆಕ್ಟ್ ಮಾಡಿ ಒಂದು 2 hours ಬ್ಲಾಕ್ ಮಾಡಿ ಇಟ್ರೆ ಅದು ರಿಯಾಕ್ಷನ್ ತರ ಆಗ್ಬಿಟ್ಟು ಬಿಗ್ ಬ್ಲಡ್ ಕ್ಲಾಟ್ಸ್ ಎಲ್ಲ ಕರಗ್ಬಿಟ್ಟು ನೀರಾಗಿ ಬೇಗ ಖಾಲಿ 6-7 ದಿವಸದಲ್ಲಿ ಅದು ಪುಡಿ ಆಗುವಂಥದ್ದು 2-3 ದಿವಸದಲ್ಲೇ ಪುಡಿ ಆಗ್ಬಿಟ್ಟು ಆ ಟ್ಯೂಬ್ ಅಲ್ಲಿ ಹೊರಗೆ ಬರುತ್ತೆ. ಟ್ಯೂಬ್ ಬ್ಲಾಕೇಜ್ ಚಾನ್ಸಸ್ ಕಡಿಮೆ ಇರುತ್ತೆ. ಸೊ ಹಂಗೆ ಆ ರೀತಿಯಲ್ಲಿ
those are the things we can do. So now what I have understood from what you're saying is, on one side medical management ಮಾಡಿದ್ವಿ, ಅದು ತೀರ್ಬಿಡ್ತು ಐ ಮೀನ್ ಕ್ರಾಸ್ ಆಗ್ಬಿಡ್ತು, ಆಗ್ತಾ ಇಲ್ಲಾಗಲಿ ಸರ್ಜರಿ ಮಾಡಿಬಿಟ್ಟು ಕ್ಲಾಟ್ ತೆಗೆದುಬಿಟ್ಟು ಪ್ರೆಷರ್ ಕಮ್ಮಿ ಮಾಡ್ತೀವಿ. ವಿ ರೆಡ್ಯೂಸ್ ದ ಕ್ಲಾಟ್ ಪ್ರೆಷರ್ ಇನ್ ದ ಕ್ಲಾಟ್ ಸೈಜ್ ಆ್ಯಂಡ್ ಪ್ರೆಷರ್ ಇನ್ ದ ಬ್ರೈನ್. And ICU treatment continues for X amount of time until the brain swelling comes down. ಮತ್ತೆ periodic scan ಮಾಡ್ಕೊಂಡು ಹೋಗಬೇಕು. ಬೇರೆ ಜ್ವರ ಬಂದ್ರೆ ಇದು ಬಂದ್ರೆ ಅದೆಲ್ಲ ನೋಡ್ಕೋಬೇಕು. ಸೊ ಇಟ್ಸ್ ನಾಟ್ ಮ್ಯಾಜಿಕಲ್ ದಟ್ ಸಡನ್ಲಿ ಹಿ ಗೆಟ್ಸ್ ಬೆಟರ್. ಮೇಡ್ ಪೇಷಂಟ್ ಆವರೇಜ್ 2-3 months ಇರ್ತಾರೆ ಹಾಸ್ಪಿಟಲ್ ಅಲ್ವಾ? 2-3 months ಇರ್ತಾರೆ. ಸಿ ವ್ಯೂವರ್ಸ್, ನೀವು 5 ಪೈಸೆ 10 ಪೈಸೆ ಟ್ಯಾಬ್ಲೆಟ್ ತೊಗೊಳ್ದೆ ದಿನ ಅದು 5 ಸೆಕೆಂಡ್ ಆಗಲ್ಲ ನುಂಗ್ಲಿಕ್ಕೆ. ಪ್ಲಸ್ BP ಚೆಕ್ ಮಾಡ್ಕೊಳ್ದೆ ನೋಡಿ, your entire life is spoiled. Sometimes life is gone or life is spoiled for life ಅಲ್ವಾ? ನಾಟ್ ವರ್ತ್ ದಿ ಎಫರ್ಟ್ ಅಲ್ವಾ? ಇವತ್ತು 100ಕ್ಕೆ 100 ಬ್ರೈನ್ ವರ್ಕ್ ಮಾಡಿದ್ರೆ ಜೀವನ ಮಾಡೋದು ಕಷ್ಟ. ಕರೆಕ್ಟ್ ಅಲ್ವಾ? There's so much of competition, so much of things going on. It is such a disability at the end of the day. Going back to your neurosurgery training, how was your neurosurgery training? What was the interesting things that you learned? How did you change? ಹೆಂಗಿತ್ತು ಟ್ರೈನಿಂಗ್? ಕಷ್ಟ ಆಯ್ತಾ, ಈಸಿ ಇತ್ತಾ?
ನಮಗೆ
ಚೆನ್ನೈ ಅಪಾರ್ಟ್ ಫ್ರಮ್ ದ ಹೀಟ್, ಬಟ್ ಯು ಆರ್ ಯೂಸ್ ಟು ಹೀಟ್ ಬೈ ದೆನ್, ಬೆಳ್ಳಾರಿ ಆಗ್ಬಿಟ್ಟು ಚಾಂಪಿಯನ್ ಆಗ್ಬಿಟ್ಟಿದೆ ಅದಕ್ಕೆ ಹೀಟಿಗೆ.
ಕ್ಲೈಮೇಟ್ ವಾಸ್ ನಾಟ್ ಎ ಫ್ಯಾಕ್ಟರ್ ದೇರ್ ಬಿಕಾಸ್ ವಿ ವರ್ ಇನ್ ಎ AC building in the hospital. Only when we come out, maybe after 36 hours or 48 hours of duty, we come out.
Correct.
So climate was not a problem. So we enjoyed actually. ಯಾಕಂತ ಹೇಳಿದ್ರೆ ನಮ್ಮ ಡಿಪಾರ್ಟ್ಮೆಂಟ್ಲಿ ಪ್ರತಿ ವರ್ಷ ಒಂದು 3 ಕ್ಯಾಂಡಿಡೇಟ್ಸ್ ಇರ್ತಿದ್ರು. ಸೊ ಆಸ್ ಎ ಟ್ರೈನಿಂಗ್ ಕ್ಯಾಂಡಿಡೇಟ್ಸ್ 15 people were there, 5-year course. So we used to have good academic activities, daily surgical ittu. So we were involved in all activities. So our teachers were very good, they were very friendly. So
lot of learning also.
A lot of learning.
Very nice. So when did you meet your life partner, Vandana? ಆ ಸ್ಟೋರಿ ಹೇಳಿ ನಮಗೆ. I think you had a more exciting story than what we had, I think.
I met Vandana when after my MBBS, when I was working as a duty doctor.
ಎಲ್ಲಿ?
In Kumble.
ಅಲ್ಲಿ ಕೋಆಪರೇಟಿವ್ ಹಾಸ್ಪಿಟಲ್ ಅಲ್ಲಿ. ಸೊ ನೋಡಿದ್ಯಾ, ನಿಮ್ಮ ಅಪ್ಪ ನೀನು ಅಲ್ಲಿ ಫೋರ್ಸ್ ಮಾಡಿದ್ರೆ ಹೋಗಿದ್ದಕ್ಕೆ ಅದೇ ಸಾರ್ಥಕ ಆಯ್ತು ಅಲ್ವಾ? ಮನೇಲಿ ಕೂತಿದ್ರೆ ಆಗ್ತಾ ಇರಲಿಲ್ಲ ಕೆಲಸ ಅದು.
So she was in the OBG section, I was in the general section as a duty doctor. So we had a small study group. 4 to 5 people, local doctors also used to come and sit and study in the day hours. So that's where I met Vandana. Then we became friends. We liked each other. Then it went on like that.
And then she came with you to Chennai.
Yeah, we both. I first joined neurosurgery. So she also then joined her DNB OBG course in Vijay Hospital, Chennai. Yeah.
So you
got married in 2007.
ಅಲ್ಲ ರಿಜಿಸ್ಟರ್ ಮ್ಯಾರೇಜ್ ಮಾಡ್ಕೊಂಡ್ಬಿಟ್ಟೆ.
No, we are from a different caste, so my parents didn't have consent for that.
God,
So,
all this aside. KP is teaching you a lot of things. So remember one thing, it's not just about all of those things. Listen, guys, the benefit of listening to a podcast is you get some tips of how to run your life apart from how to become a good doctor and a good professional and help patients get better. Yeah, I met Vandana, I met your kids, and I think you have a great family, and all the best for that. So coming back to Ido, so you trained in neurosurgery and then you have learned all these interstitial hematomas. So anything else ಇವಾಗ primary hematomas ICH ಅಂತ ಹೇಳಿದ್ವಿ. What are the other types of ICHs? You made a comment on anticoagulation ಇಂದ ಬರ್ಬೋದು. ಇದೇನು antiplatelet anticoagulation ಏನು ಈ ಮೆಡಿಸಿನ್ಸ್ ಏನು ಯಾಕೆ ಕೊಡ್ತಾರೆ what type of patients take this? If it is so dangerous, why should they take it in the first place? Can you tell our viewers about that?
many times heart and brain are enemies. So basically the cardiologist keeps giving antiplatelets, anticoagulants. They will have some processes in the heart. So they'll
Some block in the heart.
some block in the heart, stent in the heart. So they will give acosprin, aspirin, and acetylrome or newer anticoagulants, and they will be keeping the INR high. So many times the patient lands up with the bleed in the brain. Then we have to manage the anticoagulants or antiplatelets and the brain also, which becomes a tough time for us.
Tough time.
Yeah.
ಒಂದಕ್ಕೆ ಟ್ರೀಟ್ಮೆಂಟ್ ಇನ್ನೊಂದಕ್ಕೆ ಪಾಯ್ಸನ್ ಇದಕ್ಕೆ ಪಾಯ್ಸನ್ ಅದಕ್ಕೆ ಟ್ರೀಟ್ಮೆಂಟ್ ಅಲ್ವಾ ಕಷ್ಟ ಆಗ್ಬಿಡುತ್ತೆ ಅದು.
ಬೇಕು ಡಾಕ್ಟರ್ ಅದು ಇಲ್ಲಿದ್ರೆ ಆಗಲ್ಲ, ಪ್ರೊಸೆಸ್ ಕ್ಲಾಟ್ ಆಗುತ್ತೆ ಅದು ಇದು ಅಂತ ಹೇಳ್ತಾರೆ. ಏನ್ ಮಾಡೋದು?
ನಾವು ಇಲ್ಲಿ ಕೊಡ್ಲಿಲ್ಲ ಅವ್ನು ಸದೋ ಬರ್ತಾನೆ ಅಂತ ನಮಗೆ ಅನ್ಸುತ್ತೆ ಅಲ್ವಾ? ಹೌದು, ಬಿಕಾಸ್ ಇಟ್ ಕೀಪ್ಸ್ ಆನ್ ಎಕ್ಸ್ಪ್ಯಾಂಡಿಂಗ್. ಸೊ ಇಟ್ಸ್ ಲೈಕ್ ಅ ಡೆವಿಲ್ ಇನ್ ದ ಡೀಪ್ ಸಿ ಅಟ್ ದ ಎಂಡ್ ಆಫ್ ದ ಡೇ. ಸೊ ಇಟ್ಸ್ ದಟ್ ಮೀನ್ಸ್ ಇಯರ್ಸ್ ನೀವು ಔಷಧಿ ತೊಗೊಳೋದು ಒಂದು, ಅದು ಬ್ಲಡ್ ಥಿನ್ನರ್ಸ್, ಬಟ್ ಯು ಹ್ಯಾವ್ ಟು ಕಾನ್ಸ್ಟೆಂಟ್ಲಿ ಕೀಪ್ ಚೆಕಿಂಗ್ ಟು ಮೇಕ್ ಶ್ಯೂರ್, ಬಿಕಾಸ್ ಹೊಟ್ಟೆಯಿಂದ ಒಳಗೆ ಎಷ್ಟು ಹೋಗುತ್ತೆ ಯಾರು ಕಂಟ್ರೋಲ್ ಇಲ್ಲ. ಯು ಆರ್ ನಾಟ್ ಬ್ಲೇಮಿಂಗ್ ದ ಕಾರ್ಡಿಯಾಲಜಿಸ್ಟ್ ಫಾರ್ ದಟ್. All we are saying is the blood thinning medicines has its own effects. That's why he is saying that one treatment ಇನ್ನೊಂದಕ್ಕೆ ಇದು ಅಂತ we have to be constantly watching for what is happening. Sometimes ischemic stroke ಗೂ ನಾವು ಕೊಡ್ತೀವಿ, we get a blood thinners. The other people who use blood thinners are the vascular surgeons. ಕಾಲಲ್ಲಿ ಕ್ಲಾಟ್ ಆಗಿ ಎಲ್ಲ ಆದರೆ ಅದು ಒಂದು ರಿಸ್ಕ್ ಇದೆ ಅಲ್ವಾ? ಸೊ ಎನಿವೇರ್ ವಿ ಯೂಸ್ ಅ ಬ್ಲಡ್ ಥಿನ್ನರ್ ಆರ್ ಆಂಟಿ ಕೋಯಾಗ್ಯುಲೇಷನ್ ಅಂತ ಹೇಳ್ತೀವಿ, ಆರ್ ಆಂಟಿ ಪ್ಲೇಟ್ಲೆಟ್ ಮೆಡಿಸಿನ್ಸ್ ಅಂತ ಹೇಳ್ತೀವಿ. ಎನಿ ಆಫ್ ದೋಸ್ ಥಿಂಗ್ಸ್ ವಿ ಯೂಸ್, ದ ರಿಸ್ಕ್ ಆಫ್ ಬ್ಲಡ್ ಸಣ್ಣ ಆಗ್ಬಿಡುತ್ತೆ. ಸೊ ನನಗೆ ನಿಮಗೆ ಕಟ್ಟಾಗಿ ಮೂರು ನಿಮಿಷ ನಿಂತೋಗ್ಬಿಟ್ರೆ ಅವ್ರಿಗೆ ಬ್ಲಡ್ ಥಿನ್ನರ್ಸ್ಗೆ 8 ನಿಮಿಷ 10 ನಿಮಿಷ ಆಗುತ್ತೆ. ಸೊ ಬಿಕಾಸ್ ಅದು ಸಣ್ಣ ಏಟ್ ಆದ್ರೂ ಇಟ್ ಕ್ಯಾನ್ ಆರ್ ಸನ್ ರೈಸ್ ಇನ್ ಬ್ಲಡ್ ಪ್ರೆಷರ್ ಕ್ಯಾನ್ ಕಾಸ್ ಅ ಮಚ್ ಬಿಗರ್ ಬ್ಲೀಡ್ ದೆನ್ ನಾರ್ಮಲ್ ಅಲ್ವಾ? ಸೊ ಅಂಥ ಪೇಷಂಟ್ಸಲ್ಲಿ ನಾವು ರೊಟೀನ್ ಸರ್ಜರಿ ಮಾಡೋದು ಕಷ್ಟ. We have to give medicines. ಇಲ್ಲದ ಕ್ಲಾಟ್ ತೆಗೆದ ಮಟ್ಟ ತುಂಬಿಕೊಡುತ್ತೆ ಅಲ್ವಾ? ಇಟ್ ಕಲೆಕ್ಟ್ಸ್ ಬ್ಯಾಕ್. ಸೊ ವಿ ಹ್ಯಾವ್ ಟು ಗಿವ್ ಪ್ಲೇಟೆಡ್ ಟ್ರಾನ್ಸ್ಫ್ಯೂಷನ್ ಮಾಡಿ ಈ ಮೆಡಿಸಿನ್ ಹಾಕಿ ಆ ಮೆಡಿಸಿನ್ ಹಾಕಿ ಏನೇನೋ ಮಸಾಲ ಹಾಕಿ ಅದೆಲ್ಲ ಮಾಡಬೇಕಾಗುತ್ತೆ. ದಟ್ ಬಿಕಮ್ಸ್ ವೆರಿ ಬಿಗ್ ಹೆಡೇಕ್ ಫಾರ್ ಎವ್ರಿಬಡಿ ಅಲ್ವಾ? ಮ್ಯಾನೇಜಿಂಗ್ ದ ಪೇಷಂಟ್ ಬಿಕಮ್ಸ್ ವೆರಿ ಹೈ ರಿಸ್ಕ್. ಸೊ ದಟ್ಸ್ ಸಮ್ ಆಫ್ ದ ಸೆಕೆಂಡರಿ ಹೆಮರೇಜಸ್ ದಟ್ ಯು ಸಿ ವೆರಿ ಕಾಮನ್.
ನೆಕ್ಸ್ಟ್ ಸಿಚುವೇಶನ್, ಕೆಲವೊಮ್ಮೆ ಪ್ರೆಗ್ನೆಂಟ್ ಲೇಡೀಸು during delivery time they come with the bleed in the brain, cerebral venous sinus thrombosis. They come with the brain bleed. So there are many occasions where we have to take them for a surgical procedure. Blood clot ತೆಗಿಬೇಕಾಗುತ್ತೆ ಅಂತ ಹೇಳುವಂಥದ್ದು. So in that situation also we have to give balance between anticoagulation and this blood clot recurrence. ಜಾಸ್ತಿ ಆಗಬಾರದು ಅಂತ ಹೇಳುವಂಥದ್ದು. As per guideline, definitely we have to give anticoagulants,
but you have to balance it. Yeah,
correct.
Well said. In fact, there's also a risk of BP and brain hemorrhage during pregnancy. My wife was a known case of migraine. So both pregnancy time, she would get severe headache, suddenly sometimes become semi-conscious. So I think each pregnancy 3 times MRI ಮಾಡ್ಸಿದ್ರು. Because every time she said, we don't know what the hell is. And being neurosurgeon, you get over stressed of what is happening. Luckily, God, this one, nothing happened. But like I said, forewarned is forearmed, so that it's better for us to check ಮಾಡೋದು better. So we have done that. Because everybody says, doctor scan ಮಾಡಿಸೋದು ಎಲ್ಲ ನಾರ್ಮಲ್ ಆಗಿದೆ. ನೋಡಪ್ಪ ಸ್ಕ್ಯಾನ್ ಮಾಡಿಸುತ್ತೆ ಅಂತ ಗೊತ್ತಾಗುತ್ತೆ ನಾರ್ಮಲ್ ಇದೆ ಅಂತ ಅಲ್ವಾ? BP ಚೆಕ್ ಮಾಡಿ ನಾರ್ಮಲ್ ಇದೆ ಅಂತ ಹೇಳುತ್ತೆ. BP ಚೆಕ್ ಮಾಡಿದ್ರೆ ಹೆಂಗೆ ನಾರ್ಮಲ್? ಇಟ್ಸ್ ಗುಡ್ ದಟ್ ಇಟ್ ಕೇಮ್ ನಾರ್ಮಲ್. Don't think that you have wasted your money on a scan. It's good to check and make sure everything is okay, rather than not making sure that something is not okay. Before we go next, so I want to talk about your project house building. KP has a lot of talent, okay? Don't think he has one talent or two talent. He's a very multifaceted guy. First of all, ಚಿಕ್ಕ ಊರಿಂದ ಬೆಂಗಳೂರು ಬಂದಿದ್ದಾನೆ. ಬೆಂಗಳೂರು ಬಂದ್ಬಿಟ್ಟು ಬಿಫೋರ್ ಐ ಟಾಕ್ ಅಬೌಟ್ ಬಿಲ್ಡಿಂಗ್ ದ ಹೌಸ್, He's called, I don't know how many of you know Bangalore. Bangalore iddavaru ಸುತ್ತಮುತ್ತ ಗೊತ್ತಾಗುತ್ತೆ. North Bangalore, Yalanka ಅಂತ ಒಂದು area ಇದೆ, satellite town. We call him the king of North Bangalore. So KP, can you tell us what is this whole attachment and love here that you have for Yalanka and that
It's
area?
all circumstances basically. See, after my DNB qualification in Chennai in 2010, I worked with Professor K.R. Suresh Babu, my mentor, for 3 years. So by then my wife also had finished her fellowship in infertility. So having stayed in Chennai for more than 9 years.
9 years ಇದೆ ಚೆನ್ನೈಲಿ?
From 2004 to 2013. So we are basically Kannadigas. Hardly any other social activities there. No relatives. So we wanted to come back. Bangalore was an option where, but I didn't feel going back to Bangalore because it was already saturated from the point of job.
Correct.
It is a smaller place with many medical
Correct.
colleges,
Correct.
and already there were senior neurosurgeons there.
Correct.
So I thought Bangalore was an option. So I made 2 trips to Bangalore
Oh, okay.
in search of job, and I didn't get a job. I attended many interviews everywhere. There were no vacancy for a neurosurgeon then. All were full. Then one neurosurgeon one day called me and said, "Come, we'll do group practice." So I trusted and came. But somehow things didn't turn well. I was just, in the sense, it didn't happen. Group practice didn't happen.
Oh, it didn't happen at all?
It didn't happen. Then it was a very difficult time. Just from student life to consultant level, with a family, with 2 kids, coming to Bangalore, staying in a rented house.
Can you imagine?
Money is important.
Absolutely.
Whatever
See, imagine even a
it is a
neurosurgeon.
common thing for any activities in life.
Correct.
So,
Absolutely.
which was difficult for me that time. If I don't have any other job, source of income. So then I started operating wherever I get, whichever place. I started using my skill and started operating. Then we didn't have the drill systems. We had to do in hand that
Hudson brace.
Hudson brace.
Oh, adantu.
It is very difficult.
I can imagine. How many I have done like that.
So I was the first neurosurgeon to operate in the Yalanka area then.
Oh, amazing. Yeshu, when was this? 2000?
2013.
Imagine, guys, Yalanka being in Bangalore city up to 2013, no neurosurgery happened there in Yoshna Madini. It is the first satellite town of this one, but it was like a official area. Alla yaru akada hogtane irilla. Very interesting.
Still I remember the Sai Prasad hospital was the
first surgery.
First hospital.
Amazing.
Yeah.
Amazing. Yeah. So before you go, I want to make the viewers understand. Listen, guys, we are hardly any neurosurgeons in the country. In spite of that, there is no campus interview for neurosurgeons.
Yeah.
Every engineering college has campus interview. There's a Google comes, Amazon comes, they come, package and all of those things. It's literally we have to go hunting for jobs. Like he said, so many places he went, didn't get a job. Don't think, ishtala ಓದ್ಬಿಟ್ಟು ಮಾಡ್ಬಿಟ್ರೆ ಆರಾಮಾಗಿ ಎಲ್ಲರೂ ಕರೆದು ಬಿಡ್ತಾರೆ ಆಗ್ಬಿಡುತ್ತೆ ಆಗಲ್ಲ. It's a very different world. Medical practice is very, very different from, engineering, because there's no multinational corporates like Amazon and this one who hired thousands of people, because the whole project is very, very different. Continue, KP, your story about North Bangalore and how we work also together.
Meantime, I also met you basically. Yeah. So
Correct, 2013 only.
2013 we met. Then I joined with you. Still we are continuing.
Correct. Yeah, we have had a fantastic 12 years. And
very good
yes,
association
no
for the last 13 years.
13 years.
13 years.
13 years.
Very brotherly association we have.
Thank you so much.
So I have learned many things from you.
Thank you.
So especially the counseling part,
Correct.
managing the clinical seniors, so all those things. I practice in many places, and
I wouldn't say it's not typical, atypical. Most of you think doctors in corporate hospital, one job, one hospital. There's other set of doctors like us who go to multiple hospitals. I go to very few. I did that little earlier. People like him do go to multiple hospitals because that's the way the freelancing private practice is all about.
Yeah. I really thank WhatsApp for this. Otherwise, I don't think this would have happened. Because
WhatsApp.
Oh, yeah,
They should
WhatsApp,
give you
yeah.
some share in the company, I think, for promoting WhatsApp
Yeah,
or a
yeah.
podcast.
no, basically, it gives us like a telemedicine. No?
Correct.
It's in,
Quickly.
yeah.
Immediately.
In your phone, you can just see what's happening
Howದು?
on the
Correct.
bedside. A junior
Howದು,
doctor
when
can
I started
assess,
practice, just to see a scan, I had to go all the way, sometimes 1 hour driving.
or the hospital had to send you
Correct.
image to
Yeah.
some ambulance driver. So,
Correct.
those were the
2 o'clock in the morning, they'll
difficult
come
times.
home with
Yeah.
the film and I look at the film, what is happening and
Yeah.
things like that.
So WhatsApp really helped.
Howದು?
And
I
now
agree.
everyone uses it.
Correct. Immediately.
Yeah.
And you can even do the video call to see how the patient
The
is.
scans are sent,
Correct.
the patient GCS assessment, whether it's correct or
Correct,
wrong. You can
correct.
have a video call, just
Correct.
confirm what we are talking is correct or wrong. All those decisions we can make.
And you don't have to go and then reach for
Physically,
surgery.
yeah,
You can
yeah.
decide on surgery, and so by the time you go there, those decisions can be made and the time can be saved. Alva?
Yeah, many times our physical presence is not required. Only the intellectual advice is required.
When the surgery is
when
not
the
required.
surgery is required, yes, physically we go,
Correct,
we
correct.
do the work and come.
Correct.
Otherwise, a good intensivist can handle the situation.
Correct. With advice from
Yeah,
us.
yeah.
Very well said. So, WhatsApp Jai Ho. Correct. I still remember when I started my practice, Avaga white, black and white phone ittu. Then the color phone came. Color phone only, this is pre-smartphone era. Avaga MMS anta bantu.
Yeah.
I don't know whether you remember that. From
Yeah.
SMS, it became MMS.
yeah.
MMS ಅಲ್ಲಿ they could send a CT scan.
Yeah.
ಕಷ್ಟಪಟ್ಟು ಬರೋದು ಅದು ಇರಬೇಕು ಒಂದ್ಸಲ ಬರಲ್ಲ ಮತ್ತೆ ಕಳಿಸು ಫ್ರಮ್ ದೇರ್ ವಿ ಹ್ಯಾವ್ ಕಮ್ ಸಚ್ ಅ ಲಾಂಗ್ ವೇ ಅಲ್ವಾ ಯು ಕ್ಯಾನ್ ಸಿ ಡೂ ವಿಡಿಯೋ ಕಾಲ್ಸ್ ಯು ಕ್ಯಾನ್ ಸಿ ಪೇಷಂಟ್ in one lifetime we have seen so much of dramatic change that's happened, and I think it really helped people like us to do that. There was another elderly lady who had brain hemorrhage. Elderly in the 60s plus had a brain hemorrhage, and she had intraventricular hemorrhage, like you said, and she went to another private corporate hospital, and they operate both sides and put tubes and put that medicine inside for clotting, busting, and all of that. By the time she finished all of that, tracheostomy, everything, 3 weeks agittu, and she came off the ICU and ventilator. She was still deeply unconscious. So they were recommended to come to us for neuro rehab because we run neuro rehab at Rehab. One man came to meet me, advance party, before shifting the patient. So he happened to be one of the senior trustees of our hospital. So case summary ella torsidru. Admale he said, Dr. Sharan, I want to ask you an honest question. I said, what is it? Is it worth bringing the patient here for rehab? This is the exact words he used. Is it worth bringing the patient? I said, why do you ask me this question? Sir, they don't have money. I am going to fund this bill. I want to know whether it's worth it. She is my own sister. The own brother is asking me this question. Is it worth spending money on my sister? Right or wrong, good or bad, I don't want to comment on that. But this was a question asked to me.
No, that is true not only from the point of patient or patient family. From the insurance sector, there is no support for a rehabilitation
correct,
program. From the
correct.
government sector, there is no proper centers for rehab.
Correct. True.
So,
You
all
got
over
it.
it's the same psychology.
Correct. It's the same. ಇದು once ಸರ್ವೆ ಮಾಡಿದ್ರೆ
Yeah, insurance doesn't support
Correct.
rehabilitation program.
True. I agree. Many times they don't support.
Yeah.
So he asked me that. I said, sir, you should try because we have had a lot of good results. Consent form during surgery.
Yeah.
Yes. So KP, I remember this story that you were so passionate about her name. You know that girl's story. She's still a dear friend for us. Can you tell us that story?
She had a good rehabilitation program under your care, and she is back to college, I think, or work or college. Yeah.
College. Coma to college.
Yeah, come to college. So it all happened one day in a local hospital in Yelahanka. One boy and girl was brought to the hospital. ಬೆಳಗ್ಗೆ ಹೋದಾಗ ಅರೌಂಡ್ 8 o'clock ಆಸ್ಪತ್ರೆಗೆ ಕರ್ಕೊಂಡು ಬಂದಿದ್ರು. ಏನಂತೆ ಅವರು ನಂದಿ ಬೆಟ್ಟಕ್ಕೆ ಬೈಕಲ್ಲಿ ಹೋಗಿದ್ರು. ರಿಲೇಟಿವ್ಸ್ ಬೇಸಿಕಲಿ. ಸೊ
ಹುಡುಗಿ ಮುಂಬೈಯಿಂದ
ಬಂದಿದ್ದಾಳೆ. ಇಲ್ಲಿ ರಿಲೇಟಿವ್ಸ್ ಮನೇಲಿ ಇದ್ರೆ ಅಲ್ಲಿ ಹುಡುಗಿ ರಿಲೇಟಿವ್ಸ್ ಹೋಗಿದ್ದಾರೆ. ಹಂಸಲ್ಲಿ ಅವನ ಸ್ಪೀಡ್ ಹೋಗ್ತಿದ್ದ, ಹಂಸಲ್ಲಿ ಪಲ್ಟಿ ಆಗ್ಬಿಟ್ಟಿದೆ. ಹುಡುಗನಿಗೆ ಏನು ಏಟ್ ಆಗಿಲ್ಲ, ಏನೋ ಸ್ವಲ್ಪ ಎಬ್ರೇಷನ್ಸ್ ಆಗಿತ್ತು. ಗರ್ಲ್ ಈಸ್ ಅನ್ಕಾನ್ಶಿಯಸ್.
ಹೆಲ್ಮೆಟ್ ಹಾಕಿದ್ಲ ಇಲ್ಲ,
ಎಕ್ಸಾಕ್ಟ್ಲಿ ಐ ಡೋಂಟ್ ರಿಮೆಂಬರ್. ಸೊ ಸ್ಕ್ಯಾನ್ ಅಲ್ಲಿ ಲಾರ್ಜ್ ಬ್ಲಡ್ ಕ್ಲಾಟ್ ಇದೆ, ಪ್ಯೂಪಿಲ್ಸ್ unequal ಇದೆ, which is an indication that she is going to rapidly deteriorate.
And she was quite deeply unconscious at the end.
ಡೀಪ್ಲಿ ಅನ್ಕಾನ್ಶಿಯಸ್. ಸೊ ನಾನು ಹೋದವನು ನಾನು ಪೇಷಂಟ್ ಅವನು ಒಬ್ಬನೇ ಹುಡುಗ ಇದ್ದ ಪಾಪ. ಯಾಕಂದ್ರೆ ಇಟ್ ವಾಸ್ ಅರ್ಲಿ ಮಾರ್ನಿಂಗ್, ಇನ್ಸಿಡೆಂಟ್ ಹ್ಯಾಪನ್. ಗರ್ಲ್ ಈಸ್ ಫ್ರಮ್ ಮುಂಬೈ, ಹಿಸ್ ಪೇರೆಂಟ್ಸ್ ಆರ್ ಸಮ್ವೇರ್ away. They had come to Nandi Betta as a morning trip. So people were not around, only that boy was there. So but as a doctor I don't have time.
Correct. Especially
in
that
my hand,
situation.
because she is deteriorating. I need ಸರ್ಜರಿ ಮಾಡ್ಬಿಟ್ಟು ಆ ಬ್ಲಡ್ ತೆಗಿಬೇಕು, ಅವಳ ಜೀವ ಉಳಿಸಕ್ಕಾಗತ್ತೆ, ಇಲ್ಲ ಅಂದ್ರೆ ಇಲ್ಲ.
Correct.
ಸೊ ಕರೆದ್ಬಿಟ್ಟು ಅವನಿಗೆ ಹೇಳಿದೆ, ನೋಡಪ್ಪ ಹಿಂಗೆ ವಿಷಯ ಇದೆ, ಅರ್ಜೆಂಟ್ ಸಿಚುವೇಶನ್ ಇದೆ, ಮಾಡಬೇಕು. He was confused because he was a relative.
But young guy.
And he is also young guy. ಒಂದು ಮೋಸ್ಟ್ಲಿ 20 years ಏನೋ ಇದ್ದಿರ್ಬೇಕು ಅವನು. ಅವನಿಗೆ ಡಿಸಿಷನ್ ಸರ್ಜರಿ ಅಂತ ಹೇಳೋದು ಕೂಡಲೇ ಅವನು ಸ್ವಲ್ಪ ಹೆದರ್ಕೊಂಡ, ಪ್ಯಾನಿಕ್ ಆಗ್ಬಿಟ್ಟ. ಜೀವ ಹೋಗುತ್ತೆ, ಸರ್ಜರಿ ಮಾಡಬೇಕು ಅಂತ ಹೇಳಿದಾಗ, ತಲೆ ಸರ್ಜರಿ ಅಂತ ಆದಾಗ ಪ್ಯಾನಿಕ್ ಆದ. ಸೊ ಅವನು ಒಂದು ಮಾತಾಡಬೇಕು ಫ್ಯಾಮಿಲಿ ಹತ್ರ. ಆಯ್ತು, ಒಂದು ಮಾತಾಡೋ, ನಿಂಗೆ ತುಂಬ ಟೈಮ್ ಇಲ್ಲ ಅಂತ ಹೇಳಿದೆ. 10 minutes ಆದ್ರೆ ಅವನು ಒಳಗೆ ಬಂದಿಲ್ಲ. ಐ ಬಿಕಮ್ ರೆಸ್ಟ್ಲೆಸ್ ಬಿಕಾಸ್ ಐ ನೋ ವಾಟ್ ಈಸ್ ದ ಟೈಮ್ ದೆನ್. ಐ ಆಮ್ ಲೂಸಿಂಗ್ ಟೈಮ್ ಬಿಕಾಸ್ ಈಗ ಏನಂತ ಹೇಳಿ ನಾವು ಸರ್ಜರಿ ಹೇಳಿದ ಕೂಡಲೇ ಸರ್ಜರಿ ಆಗಲ್ಲ.
Correct. So much process is
there is
there
a lot of process. At least 4 hours duration is there to give the actual benefit of surgery from the point of decision making.
Correct.
So which people will not understand. ನಮಗೆ ಲಾಜಿಸ್ಟಿಕ್ಸ್ ಅರೇಂಜ್ ಮಾಡಬೇಕು, ಅನಸ್ಥೆಸಿಯಾ ಡಾಕ್ಟರ್ ಬರಬೇಕು. Unless skull is opened, the surgery is not done.
Correct.
ಸೊ ನಾನು ರೆಸ್ಟ್ಲೆಸ್ ಆದೆ. ರೆಸ್ಟ್ಲೆಸ್ ಆಗ್ಬಿಟ್ಟು ವಾಪಸ್ ಕರೆದೆ. ಅವನು ಇಲ್ಲ ಸರ್, ಅವ್ರು ಬರ್ತಾರೆ, ಇವ್ರು ಬರ್ತಾರೆ ಅಂದರೆ, ಫಸ್ಟ್ ಆಫ್ ಆಲ್ he was hesitant in telling the incident to somebody, his family. It has happened. Somehow he has told, but this severity he could not explain. So he was in a dilemma. Then I really got angry. I just blasted him left and right. ಹೀಗೆ ಮಾಡಿದ ಅವಳು ಹೋಗ್ಬಿಡ್ತಾಳೆ, so you have to give consent. ಹಂಗೆ ಜೋರು ಮಾಡ್ಬಿಟ್ಟೆ. I scolded him. So then he signed. So then I took her for the surgery.
Gun point ತರ ಮಾಡ್ಬಿಟ್ರೆ,
ಆ ತರ ಮಾಡುವ ಪರಿಸ್ಥಿತಿ ಬಂದ್ಬಿಡ್ತು.
Correct.
Because the people were not understanding. They were thinking they have time, which was not true then. And nobody there also, no one was understanding other people. So then the point of consent ಅಲ್ಲಿ ಬರುತ್ತೆ. So without their consent ಅಂತ ಹೇಳೋ ಒಂದು ಪಾಯಿಂಟ್, again there are different types of consent.
Correct.
Ordinary consents, high risk consent, informed consent,
death on table consent.
Death on table.
Correct.
Ultimately they're all in the paper. It's basically the mutual trust between the patient and the doctor. Ultimately it works. How much ever you write in a paper and get a sign,
Like any other contract.
Any
MOU, any contract is the same at the end of the day.
When there is a dispute, all this debatable, all these consents.
Correct.
But if it is not there, it becomes a major
impossible for us.
Impossible for us to defend.
Correct. To execute.
Yeah.
Correct. So you took a high risk consent and you did
the
and
surgery.
she was very sick when she came to us for rehab, and now I meet her in Mumbai. She calls me and says, can I make a tattoo here? Can I make a tattoo there? Can I color my hair? Every time I go to Mumbai to operate, she comes and meets me. She's such a joyful girl. She's near normal today. It's amazing. So I keep telling KP sir that what you've done. Yeah, tell hi from my side. So she's Vidhi, wherever you are, we love you, for what you have done. So that is destiny, KP. At the end of the day, whatever you did, you did it in the goodwill of what is happening, and the result is there for all to see. So guys, please remember, this doctor-patient relationship has to be one built on trust, and adidrene it is going to make the magic happen. And somewhere, not just doctor, anywhere the relationship has to be based on trust. Alva, nambike ilde idre kelsa agalla. So that's what it is. So coming back to Project Hope. So tell us your story about what is this house, because lot people normally like to stay in an apartment complex, with all this facility, but KP was unique. He built his own independent house. So KP, over to you for your house project.
ನಾನು ಬೇಸಿಕಲಿ 2007 ಇಂದ ರೆಂಟಲ್ ಅಪಾರ್ಟ್ಮೆಂಟ್ ಅಲ್ಲಿ ಇದ್ದೆ. 4-5 ರೆಂಟಲ್ ಅಪಾರ್ಟ್ಮೆಂಟ್ ಚೇಂಜ್ ಆಯಿತು ಬಿಕಾಸ್ ಆಫ್ ದಿ ಚೇಂಜ್ ಇನ್ ದ ಪ್ಲೇಸ್ ಆಫ್ ವರ್ಕಿಂಗ್, ರಿಲೊಕೇಶನ್ಸ್ ಅಂಡ್ ಆಲ್ ದೋಸ್ ಥಿಂಗ್ಸ್. ನಾನು ಬೇಸಿಕಲಿ ಹಳ್ಳಿ ಹುಡುಗ.
ಹಳ್ಳಿ ಹುಡುಗ.
ಹೌದು ಹೌದು. ಸೊ ನಮ್ಗೆ ಮಂಗಳೂರು ಸೈಡಲ್ಲೆಲ್ಲ ಮನೆ ಒಂಟಿ ಮನೆಗಳು ಇರುತ್ತೆ, ಅಲ್ಲೆಲ್ಲ ಒಂದು ಗುಡ್ಡದಲ್ಲಿ ಒಂದೊಂದು ಮನೆ ಇರುತ್ತೆ, ತೋಟದ ಮಧ್ಯೆ ಇರುತ್ತೆ. ಸೊ ದಟ್ಸ್ ಹೌ ವಿ ಹ್ಯಾವ್ ಬ್ರಾಟ್ ಅಪ್. ಅಪಾರ್ಟ್ಮೆಂಟ್ ಅಲ್ಲಿ ಇದ್ರೆ ಸುಮಾರು ರಿಸ್ಟ್ರಿಕ್ಷನ್. ಮಳೆ ಬಡಿಬೇಕಾದ್ರೂ ಆ ಪಕ್ಕದೊಂದು ಗಲಾಟೆ ಮಾಡೋದು, ಚಪ್ಪಲಿ ಹೊರಗೆ ಇಟ್ರೆ ಇವನು ಗಲಾಟೆ ಮಾಡೋದು. ಸೊ ಹಿಂಗೆಲ್ಲ ಇಟ್ ಯೂಸ್ ಟು ಹರ್ಟ್. ಪ್ರೈವಸಿ ಇಲ್ಲ ಅಂತ ಹೇಳೋ ಒಂದು ಪಾಯಿಂಟ್ ಮನಸ್ಸಿಗೆ ಬರ್ತಾ ಇತ್ತು. ಎರಡನೇದು, ಯಾವಳು ಅಡಿ ಸ್ಥಳ ನಂದಲ್ಲ, ಮೇಲೂ ನಂದಲ್ಲ.
ಕರೆಕ್ಟ್.
ಕಾಂಕ್ರೀಟ್ ರೂಫ್ ಮಾತ್ರ ನಂದು. ಅದು ಇನ್ನೊಂದು ಕಾನ್ಸೆಪ್ಟ್. ಸೊ ಹಾಗಾಗಿ ನನ್ನ ವೈಫ್ ಜೊತೆ ಡಿಸ್ಕಸ್ ಮಾಡಿದಾಗ ಆಯ್ತು, ನಾನು ಹುಡುಕ್ತೇನೆ ಅಂತ ಹೇಳಿದ್ಲು.
ಹೌದು, ವಂದನ ಇಸ್ ವೆರಿ ಡೈನಮಿಕ್. ಐ ಅಗ್ರಿ ವಿತ್ ದಟ್.
ಸೊ ವಂದನ ಸ್ಟಾರ್ಟೆಡ್ ಸರ್ಚಿಂಗ್. ಯಾಕಂದ್ರೆ ನಾನು ಹಿಂಗೆ ಓಡಾಡ್ತಾ ಇದ್ದೆ ಜಾಬ್ಗೋಸ್ಕರ. ಜಾಬ್ ಅಲ್ಲಿ ಪ್ರಾಕ್ಟೀಸ್. ಐ ಯೂಸ್ ಟು go around. I didn't have much time.
Correct.
So she was then little free because my kids were small. She was not working that actively then. She was at home taking care of the
she had slowed down a little bit.
Yeah. So she had time, so she went on search of different brokers, and then we found a site.
Yeah, beautiful location. Yeah. I love that place. Yeah.
So ತಗೊಂಡು ಒಂದು 2 ವರ್ಷ ಆದ್ಮೇಲೆ ಮತ್ತೆ again when you go to bank, they ask to give loan, they ask your financial sheet.
Correct.
Unless it's all multiplication of your annual income.
Correct.
So I had to wait for 2 more years to get a good amount of loan. To build the house.
ನಾನು ಎಲ್ಲರಿಗೂ ಹೇಳ್ತೀನಿ, ನೋಡಪ್ಪ, ನಾವೆಲ್ಲ ಮಾಡೋದು ಒಂಥರ ಕೂಲಿ ಕೆಲಸ ತರ, ಡೈಲಿ ವೇಜಸ್, ಬಿಕಾಸ್ ವಿ ಡೋಂಟ್ ಗೆಟ್ a fixed salary. It all depends on how many patients we operate. And I tell everybody, if I operate, I make money. No operation, no money. It's like ಕೂಲಿ ಕೆಲಸ. At the end of the day, it's like daily wages. Whether I make 10 rupees or 10,000 rupees or 1 lakh rupees, depends on that. So it all works like that, guys. So we are very comfortable with looking at some months more, some months less. It goes on like that depending how the patients come. It's a part of the freelance practice. It's a different way of looking at it, ಅಷ್ಟೇ. So
ಹಾಗೆ ಮನೆ ಕಟ್ಟಬೇಕು ಅಂತೇಳಿ ನಾವು ಪ್ಲಾನ್ ಮಾಡ್ಕೊಂಡು ದೆನ್ ಸ್ಟಾರ್ಟ್ ಮಾಡಿದ್ವಿ.
Okay.
ಸೊ ಸ್ಟಾರ್ಟ್ ಮಾಡಬೇಕಾದ್ರೆ ಐ ವಾಂಟೆಡ್ ಎ ಕಂಪ್ಲೀಟ್ ಹೌಸ್. ಇನ್ ದ ಸೆನ್ಸ್ ಸುಮಾರು ಕನಸುಗಳು ಇತ್ತು, ಹಂಗ್ ಬೇಕು ಹಿಂಗ್ ಬೇಕು ಆಗ್ಬೇಕು ಅಂತ ಹೇಳು. ಸೊ ಅದಕ್ಕೋಸ್ಕರ
ಎಲ್ಲ
ಸೇರಿಸ್ಬಿಟ್ಟು ಮಾಡುವ ಟೈಮ್ಗೆ ಮಾಡಿ ಮುಗಿಸೋಣ.
ಜೈ ಬಜರಂಗ್ ಬಲಿ. So KP has a beautiful 7-bedroom house. He's got a swimming pool on his top floor. All imagine a small town guy from a small village from Kannada medium school has come into Bangalore city and pushed and pulled his way and established. He's a great surgeon, so he's really established his reputation and his skill sets. Yeah, great work, KP. ಅದು ಮುಗಿಸೋಂಗಿಲ್ಲ, ಏನೇನು ಮಾಡಿದೆ ಹೇಳೋ. ಅದು ಮನೆ ಕಟ್ಟದಲ್ಲಿ he was literally hands on. ನಾನು ಹೇಳ್ದೆ, next time I'll take his advice ಅಂತ. You have to give us some advice on what all you did, how you bought timber and everything else. Doc, why did you do all of that?
No, by nature I'm a person who goes deep into the whatever issue. Just I don't brush it. ಅವ್ನು ಮಾಡ್ತಾನೆ, ಕಮಿಷನ್ ಅಲ್ಲಿ ಕೊಟ್ಬಿಟ್ರೆ ಮುಗಿಸ್ಬಿಡ್ತಾನೆ ಅವನು, ಕಾಂಟ್ರಾಕ್ಟರ್ ನೋಡ್ಕೊಳ್ತಾನೆ ಅಂತಲ್ಲ. I always like to get involved, know better. I think it as in my experience, my own education, my own experience. So ಏನಾಯ್ತು, ಫಸ್ಟಿಗೆ ಫೌಂಡೇಶನ್ ಹಾಕ್ಬೇಕಾದ್ರೆ ನಮ್ಮ ಇಂಜಿನಿಯರು, ನಾನು ಅಷ್ಟು ತಲೆ ಕಟ್ಸ್ಕೊಂಡಿಲ್ಲ ಅವಾಗ ರೆಡಿ ಮಿಕ್ಸ್ ಕಾಂಕ್ರೀಟ್ ಬಂದು ಹಾಕಿದ್ರು. ನಾನು ಎಲ್ಲ ನೋಡ್ತಾ ಇದ್ದೆ, ಯಾಕಂದ್ರೆ ನನಗೆ ಮೊದಲು ಮನೆ ಕಟ್ಟುವ ಒಂದು ಎಕ್ಸ್ಪೀರಿಯನ್ಸ್ ಇರಲಿಲ್ಲ, ನಾಲೆಜು ಇರಲಿಲ್ಲ. ಐ ವಾಸ್ ಜಸ್ಟ್ ಗೆಟ್ಟಿಂಗ್ ಹೆಲ್ಪ್ ಫ್ರಮ್ ದಿ ಕಾಂಟ್ರಾಕ್ಟರ್. ಅವರು ರವಿ ಅಂತ ಅವರು ಹೆಸರು. ಸೊ ಈ ವಾಸ್ ಇಂಟೆಲಿಜೆಂಟ್. ಈ ಕಾನ್ಫಿಡೆನ್ಸ್ ಟೋಲ್ಡ್, ಸರ್ ಎಕ್ಸೆಸ್ ಬಿಲ್ ಮಾಡ್ತಾ ಇದ್ದಾರೆ ಅಂತ ಹೇಳಿ. ಏನು ಎಕ್ಸೆಸ್ ಬಿಲ್ ನಂಗೆ ಅರ್ಥ ಆಗಿಲ್ಲ. ಇಲ್ಲ ಸರ್, ಇದು ವಾಲ್ಯೂಮ್ ಇಷ್ಟಿದೆ, ಬಟ್ ಅವ್ನು ರೆಡಿ ಮಿಕ್ಸ್ ಜಾಸ್ತಿ ಹಾಕವನೆ, ಸೊ ಏನೋ ಮೋಸ ಇದೆ ಅಂತ ಹಂಗೆ ಮಾತಾಡೋಣ. ದೆನ್ ಡಿಸ್ಕಷನ್ ಆಯಿತು. ಅವರು ಫಸ್ಟ್ ಒಪ್ಪಲಿಲ್ಲ, ಮತ್ತೆ ಎಲ್ಲ ಇದು ಮಾಡಿ ಅದು ಒಪ್ಪಿದ್ರು. ಹಿ ಸೇವ್ಡ್ ಮೀ 25,000 rupees ಮೈ ಕಾಂಟ್ರಾಕ್ಟ್. ಸೊ ದೆನ್ ದ್ಯಾಟ್ ಮೇಡ್ ಮೀ ಲಿಟಲ್ ಮೋರ್ ಕಾಶಿಯಸ್ ಅಬೌಟ್ ವಾಟ್ಸ್ ಹ್ಯಾಪನಿಂಗ್. ಯಾರನ್ನು ಟ್ರಸ್ಟ್ ಮಾಡುವಂಗಿಲ್ಲ. ಸೊಸೈಟಿಲಿ ಡಾಕ್ಟರ್ ಅಂತ ಹೇಳಿದ್ರೆ ಏನ್ ಬೇಕು ಮಾಡ್ಬಿಡ್ತಾರೆ ಅಂತ ಹೇಳೋ ಒಂದು
ಟೈಮ್ ಇಲ್ಲ, ಅರ್ಥ ಆಗಲ್ಲ ಅಂದ್ಬಿಟ್ಟು ಒಂದು ಕಿವಿಯಲ್ಲಿ ಹೂವು ಇಡ್ಬೋದು,
ಆ ಥರ ಫೀಲಿಂಗ್ ಆಯಿತು. ಸೊ ಅದೊಂದು ಎಕ್ಸ್ಪೀರಿಯನ್ಸು. ಎರಡನೇದು, ದೆನ್ ಐ ಸ್ಟಾರ್ಟೆಡ್ participating in all activities.
Mm.
Like timber, for
Mm.
example.
Mm.
ಏನು ವೆರೈಟಿ ಟಿಂಬರು ಹಾಕಬೇಕು,
Mm.
ಎಲ್ಲಿಂದ ತರಬೇಕು,
Mm.
ಆಕ್ಷನ್ಗೆ ಕರ್ನಾಟಕ ಫಾರೆಸ್ಟ್ ಡಿಪಾರ್ಟ್ಮೆಂಟ್ ಆಕ್ಷನ್
Mm.
ನಿಲ್ತ್ಬಿಟ್ಟು
Mm.
ಸುಬ್ರಹ್ಮಣ್ಯಕ್ಕೆ ಹೋಗ್ಬಿಟ್ಟು
ನೋಡು ಇವೆಂಟ್ ಸುಬ್ರಹ್ಮ ಲಾರಿ ಎಲ್ಲ ತಗೊಂಬಂದು
ಇಟ್ಸ್ ಎಕ್ಸ್ಪೀರಿಯನ್ಸ್ ಬೇಸಿಕಲಿ.
I remember that activity.
ಫಾರೆಸ್ಟ್ ಆಫೀಸರ್ ಆಕ್ಚುಲಿ ಹೇಳಿದ್ರು, ಯಾಕೆ ನೀವು ಬಂದು ಯಾರನ್ನ ಕಳಿಸ್ಬೋಯ್ತಲ್ಲ ಅಂದೆ. ಇಲ್ಲ, ಇಟ್ಸ್ ಎಕ್ಸ್ಪೀರಿಯನ್ಸ್ ನಂಗೆ ಅದಕ್ಕೆ ಬಂದೆ ಅಂತ
ಪದೇ ಪದೇ ಅಂತೂ ಮನೆ ಕಟ್ಟಾಗಿಲ್ಲ.
ಸೊ
ರಾಮ.
ಅದೇ ರೀತಿ ಭದ್ರಾವತಿಯಿಂದ
ನಮ್ಮ ಅಪ್ಪ ಹೇಳ್ತಾ ಇದ್ರು ಅವ್ರು ಶಿವಮೊಗ್ಗದ ಟೀ ಕಟ್ಸೋದಂತ. The moment you said that, I told my father, see KPS and what you have done.
ಭದ್ರಾವತಿಗೆ ಹೋಗಿದ್ವಿ. ಸೊ
ಟೀ ಕೂಡ ಅಲ್ಲಿಂದ ಬರುತ್ತೆ. ಲಾಟ್ ಆಫ್ ಟೀ
ಹೌದು,
ಇನ್ ಭದ್ರಾವತಿ ಶಿವಮೊಗ್ಗ ಸೈಡ್.
ಈ ಜಲ್ಲಿ ಹೆಂಗೆ ಮರಳು ಅದನ್ನು ಎಮ್ ಸ್ಯಾಂಡ್
ಕಲ್ತಿದ್ದ ನಾನು.
ಎಮ್ ಸ್ಯಾಂಡ್ ಅಂದ್ರೆ ಏನು, ಎಷ್ಟು ವೆರೈಟಿ ಇದೆ. ಸೊ ಕ್ರಷರ್ಗೆ ಹೋಗಿದ್ದೆ, ಅದೆಲ್ಲಿ ಬಂಡೆಕಲ್ಲು ಬ್ಲಾಸ್ಟ್ ಮಾಡ್ತಾರೆ ಅಲ್ಲಿಗೆ ಹೋಗಿದ್ದೆ. ತಿಳ್ಕೊಬೇಕು ಅಂದ್ರೆ ಹೆಂಗೆ ಹೋಗಿ ನೋಡ್ಬಿಟ್ಟು, ಸೊ ಮೈ ಫ್ರೀ ಟೈಮ್ ವಾಸ್ ಯೂಸ್ಡ್ ಲೈಕ್ ದಟ್. ಸೊ ಆ ತರ ಎಲ್ಲ ಹೋಗಿ.
See guys, imagine he has got free time. So you can imagine. Very nice.
ರೀತಿಯಲ್ಲಿ
ತುಂಬಾ ಚೆನ್ನಾಗಿದೆ. I mean, we have been to your house. It's the locality. I should again appreciate Vandana for selecting a very nice location. ಅಲ್ಲಿ ಎಂದು ಬಿಸಿ ಆಗೋದಿಲ್ಲ ಕೆಪಿಆರ್ ಅಲ್ವಾ? That is a nice like ಕಲ್ಡಿ ಸಾಕ್ ತರ ಇದೆ ಅದು. So you it never become a messy ಕೋರಮಂಗಲ ಆ ಥರ ಎಲ್ಲ ಮೆಸ್ ಆಗ್ಬಿಡುತ್ತೆ ಕೆಲವು ಜನ ಕಮರ್ಷಿಯಲ್ ಆಗ್ಬಿಟ್ಟು. I think it will be a nice cute residential place at the end of the day. Very nice. Good. I think so. As we wind down, what are the messages you want to give our audience about intracerebral hematoma agli? And what are the take-home messages that you want to give people?
Periodic health checkup, basically. Maybe in young patients less than 50, once in a year, visit a doctor, have a general checkup, blood checkups, master health checkup. More than 50 years, once in 6 months, you can have a master health checkup.
You are 25 years and check ಮಾಡೋದು better ಅಲ್ವಾ? Because younger people you are getting.
You say that people may say you are scaring us.
BP at least.
Yeah, BP, yes.
BP check ಮಾಡ್ಕೊಳ್ಳಿ ತಪ್ಪೇನಿಲ್ಲ.
So any alarming signs which is routinely not a normal variation. See, many things are normal variations in the body which each individual has to recognize. So when they feel it is not normal, something else is happening to me, they better don't neglect.
Correct.
So go and visit a doctor. And doing scans is nothing wrong. Many people say over investigating. Yes, out of 100 scans, if 90 scans are normal, it's okay. But 10 people benefit out of that.
Correct.
For whom we may reduce the disability, save life.
Correct.
There are many things. Incidental findings can happen. What we think can happen. So on the scan model, ತಪ್ಪಿಲ್ಲ.
ನಿಜ.
So
in this age and time and age, evidence based medicine practice ಮಾಡೋದು ತಪ್ಪೇನಿಲ್ಲ. It should be a standard of care. You can't just ಮುಖ ನೋಡ್ಬಿಟ್ಟು ನಿನ್ನ ಮುಖ ನೋಡಿ ಬ್ಲಡ್ ಪ್ರೆಷರ್ ಹೇಳಂಗಿಲ್ಲ, ನಿನ್ನ ಮುಖ ನೋಡಿ ನಿನ್ನ ಶುಗರ್ ಹೇಳಂಗಿಲ್ಲ. If they're willing to get the sugar and BP tested, might as well get everything else tested.
And once into a disease, for example, one who has suffered a disease like ICH I2, then they should understand the disease, understand how it will be, how I should cope with the new way of life with the new disabilities. So
both patient and the family.
Both the patient and family. Because psychology is totally different.
True. That's where rehabilitation plays.
Rehabilitation has to be done.
Correct.
They should not go for a depression. So the workplace should be very cooperative.
Correct. Very true. Yeah. Very true. So the message from my side is, like I said here very clearly, high BP is one of the biggest and commonest culprit. ದಯವಿಟ್ಟು ಚೆಕ್ ಮಾಡ್ಕೊಳ್ಳಿ, ಪದೇ ಚೆಕ್ ಮಾಡಿ, ಏನು ತಪ್ಪಿಲ್ಲ. ಇಟ್ ಟೇಕ್ಸ್ ಲೆಸ್ ದೆನ್ 1 minute ಟು ಚೆಕ್ ಮಾಡಿಕೊಂಡು ಕರೆಕ್ಟಾಗಿ ಮಾಡ್ಯುಲೇಟ್ ಮಾಡಿ. ಔಷಧಿ ತೊಗೊಂಡ್ರೆ ಎಲ್ಲ ನಾರ್ಮಲ್ ಇರ್ತಂತನೂ ಅಗತ್ಯ ಇಲ್ಲ. You keep checking periodically even when you are on high BP medicines to make sure everything is under control. Catch things early, go early to the hospital and get scans done to make sure you're all right. And in case God forbid ಆಗೋಯ್ತು, hemorrhage ಆಗೋಯ್ತು ಅಂದರೆ ಧೈರ್ಯ ಇಟ್ಕೊಳ್ಳಿ. Because there are a lot of things that we can do, surgery and everything else to save. We have had enough patients who gone like that lady who came to us and who gone back to life. I'll tell you one more story here. There was another elderly lady who had brain hemorrhage. Elderly in the 60s plus had a brain hemorrhage. And she had intraventricular hemorrhage, like you said, and she went to another private corporate hospital, and they operate both sides and put tubes and put that medicine inside for clotting, busting, and all of that. By the time she finished all of that, tracheostomy, everything, 3 weeks agittu, and she came off the ICU and ventilator. She was still deeply unconscious. So they were recommended to come to us for neuro rehab because we run neuro rehab at either. One man came to meet me, advance party, before shifting the patient. So he happened to be one of the senior trustees of our hospital. So case summary ella torsidru. Admale he said, Dr. Sharan, I want to ask you an honest question. I said, what is it? Is it worth bringing the patient here for rehab? This is the exact words he used. Is it worth bringing the patient? I said, why do you ask me this question? Sir, they don't have money. I am going to fund this bill. I want to know whether it's worth it. She is my own sister. The own brother is asking me this question. Is it worth spending money on my sister? Right or wrong, good or bad, I don't want to comment on that. But this was a question asked to me.
No, that is true not only from the point of patient or patient family. From the insurance sector, there is no support for a rehabilitation program. From the government sector, there is no proper centers for rehab.
Correct. True.
So, all over it's the same psychology.
It's the same. Once
insurance doesn't support rehabilitation program.
True. I agree. Many times they don't support.
Yeah.
So he asked me that. I said, sir, you should try because we have had a lot of good results. So he had heard about us and what we do. He said he brought the patient. And you won't believe it. Initial 1 month was very stormy, period. She was in hospital, inpatient for 3 months, outpatient for 3-4 months. She's today walking with a walker. She's talking. Everything is close, eating. She's, there's a video of her making chapati and all of those things. So she's reached that level of functioning. So from a place where the brother asked me, is it worth bringing her here? Today the family is very happy. So it's very important for us. I'm not saying every patient gets the same result, but remember, I think every patient should get the same effort from everybody, because who is on this side, who is on that side, only destiny will tell us. God only knows what is going to happen. Now God WhatsApp message WhatsApp. So we have to try our own thing. So guys, please take care. Prevention is the best, safest and cheapest cure. But in case something bad happens, go to a neuro-ready hospital, stroke-ready hospital quickly. Make sure you get the right diagnosis, right treatment with the right specialist, and only then you can expect the right results to happen. And remember, time is health and wealth. You have to move very fast, and that's what it is. So fantastic. So I think that was a very important aspect of care that you covered, high-risk consent, especially in emergencies.
Yeah.
And death on table is something, that we do very commonly. We see that happening, how death on table, and sometimes when the patient is going to operate, they can even die during surgery because of the multiple risk factors they have, BP, sugar, cardiac problems and things like that. But very few people die on table, it's very hypothetical. And many of them not only survive, they do very well, many of them back at work, but our time risk is very high. So guys, when you hear all these things, bhayapadkobedi, just understand, decision ಮಾಡಬೇಕು, because many of these things, time is a critical factor. It's karo ya maro at the end of the day. And if you lose that window period of recovery, the same thing done by the best of surgeons don't give us the best result.
Yeah, correct.
So thank you very much, KP. I think it was a fantastic chat we had.
Thank you, sir.
It was a pleasure. And thank you for all the partnership. I've enjoyed every moment of my thing, and many, many more decades of us partnership together.
Yeah, yes,
thank
sir.
you.
I really enjoy the partnership, sir.
Yeah. Thank you very much.
Namaste.
So KP, we have a customary, this one of giving a gift of a book to each of our guests.
Thank you,
this
sir.
is our book that we have written, Rebooting the Brain.
Yeah.
Please give your opinion on that, and that's what it is.
Yeah. Thank you.
You can look at the camera.
Very, very brilliant title for the book.
I know. Now brain ಬಗ್ಗೆ ಮಾತಾಡಿದ್ರೆ nobody understands. Now ಇದು technology ಬಗ್ಗೆ ಮಾತಾಡಿದ್ರೆ everybody ಅರ್ಥ ಆಗುತ್ತೆ. That's what it is.
Because it being radioactive, it's a challenge. And as you rightly pointed out, you actually have to, bury it, really dig it.
I heard about that.
And then, even in some countries would like to have that coordinates, because that whole area would also get radiated. So you can't have people
still
living there. Yeah.
Even if you bury it,
people won't be able to live there. So there was a big change that was bound to happen. There is a limit that you can use Mother Earth also.
Correct.
And electricity became that source where you can generate photons in a very, very easy manner and target it. The other thing from a patient viewpoint also changed. And it goes back in those days, there was no early diagnosis.
Correct.
By the time people used to have cancers, you had this big lesions, like really big lesions. what choice doctors had. As a neurosurgeon, what choice you had? Nothing. You only were into palliative management. Even if you wanted a curative treatment, you couldn't do it. So the need came in, and I think that drove people with passion and love to work on it, whether it came from clinician or whether it came from medical technology companies, and they moved directionally towards fulfilling other objectives. So primary objective was always treat the cancer.
Correct.
But then two more objectives came in, which is preservation of anatomy and preservation of function.
Correct.
And in today's world, as we stand today, I think we meet all the three objectives.
So without naming anybody, can you give some of the scenarios of gubbers in your life that you can? Because people should not think, Sudhir was born with the golden spoon, Piyush is born, he's a lucky guy. We are like this, we are, what can I do? I come from a small town, I don't have a godfather, I didn't have this. So can you just tell people where you come from? Did you come from some royal family or what is going on? So I start with you.
No, but coming back to Gabbar again, I would say that the Gabbar is not an individual per se. I think the Gabbar is the mentality of the people who think that who are not willing to accept a change or something which new is going to happen. All right, that's the biggest Gabbar we have right now in the market.
What a
Right.
statement.
I go.
Whoa.
That's the Gabbar. I mean, you go into certain doctor who's been using certain technology for a very long time, and he's not willing to let that go. He doesn't want to change. Now, going back to him and saying that you do this is going to help the patient as well, that takes a lot of time. And that's changing. I think I'm looking at the younger generation of doctors are willing to change. And I think, that's where we are.
So one of the
overcoming
gubbers
that
you're
gap.
saying is a mindset, and
The
we
mindset.
have a flexible mindset is very
Absolutely,
critical.
yeah.
Whoa.
That's what
an
I would say.
amazing,
Yeah.
amazing.
You can't say that right from the day one, if you're building up a career seriously, your work-life balance is going to be like, you can give gyan to people that no, it has to be there and all. There has to be a sacrifice. But as you grow older, as the family also grows older, I think you need to give those times, specific times, especially when the requirement demands.
Correct.
You need to be with the kid. I mean, you need to attend the classes. If at all you need to go to her school or the child's school, you have to go. I mean, these are important things in life, because as you grow older, your career at one point in time becomes unimportant. The family becomes important. And that's the time you should be smart enough to make a switch. And you need to put it, you need to
You need to take
program
responsibility
it.
for
You
that.
have to take the responsibility for it. Now, I would say, up to a certain age, it's important. Job is important. Job security is important. You need to work. Money is important. You do it all the right way. Yeah, you compromise on certain things. You go back, settle it with the family. But I think that cannot continue lifelong. You got to put it on a certain age. You have to stop it.